members and the delegates to the second day of the 6th annual Jammu Trauma virtual meet. So we had a very good discussion yesterday on various topics. So without much wasting of time, I would request the speaker, the first speaker, Dr. Siddarth Sharma, who is from PGH Chandigarh, who will enlighten us about the operative management of Lisp frank injuries. Over to Dr. Siddarth.
Thank you. Thank you, Dr. Sanjeev, sir. And thank you, the organizers of the Jammu Trauma Society meeting. Okay. Sanjeev, sir, am I visible? Is my screen visible?
Yes,
and
yes.
Am
Go
I
on,
audible,
please.
sir?
Perfectly fine.
Right.
Go on.
Right. Thank you, sir. So as the opening batsman of the second day of the JTS meeting, the first day of which was an absolute hit, I will be speaking today on operative management of Lisp frank injuries. And very cheekily, I had added a subtitle, Everything You Need to Know. Well, you know, after a little bit of introspection, I realized I possibly cannot tell you everything that you need to know about this in 10 minutes. So this is almost everything that you need to know. So the learning objectives of this talk, hopefully, you know, they're very simple. We will be talking only of the operative management because this is really a very vast topic. So I will be discussing when do you operate these injuries, which procedure should you do for which type of injuries, how do you operate them, and mind you, this is all based on case-based scenarios. So the first thing we need to know when you talk of Lisp frank injuries, that all injuries are not the same. This is perfectly the case of apples not being the same as oranges. And here on your left side of the screen, you have a high velocity injury which has multiple dislocations, whereas on the right side of your screen, you have a low velocity injury which, if you were not careful enough, you could miss. So broadly speaking, there are many classification systems, but this is so helpful if you start classifying your Lisp frank injuries as high and low energy mechanisms. So the high energy mechanisms occur with road traffic accidents or fall from a significant height. These are associated with severe soft tissue compromise. So these are the ones which will have blisters, soft tissue swelling, compartment syndrome. More or less all the three columns of the foot are involved. I will be talking about the columns very shortly. Most of these injuries are fracture dislocations as opposed to ligamentous injuries, and very, very important that the instability may extend proximally into the cuneiforms, even into the talonavicular joint. So you must be very careful. So on the other hand, you have the low energy mechanisms. These may happen when the person twists their foot, the foot gets stuck in a pothole. So typically they have very less soft tissue compromise, minimal compromise. More or less, it's the medial column which is involved. And why this is involved, I'll be telling you again very shortly. And most of these tend to be ligamentous injuries. So the operative management, when we talk of this, really depends upon whether you are dealing with a low energy variant, a high energy variant, or a neglected version of low energy or high energy variant. And mind you, this is again very important because in our setups, we do tend to get a lot of neglected injuries as well. And I will be talking about these. So what are the principles of management or operative management of Lisp frank injuries? The foremost thing is joint congruity. Now the Lisp frank joints are small joints, but even step-offs of more than 2 millimeters result in altered biomechanics, altered load transmission across these joints, arthrosis, and Lisp frank arthrosis is painful and disabling to the patients. The second important principle, but which is nonetheless as important as the first principle, is restoration of the column lengths. So here, this is the principle of the step-off, and as you can see here, the metatarsal of the second metatarsal has shifted laterally. It's a small step-off, but small step-offs can result in arthrosis and pain. Now I talked of the column lengths. So some of you may know this, but let's revise this nonetheless. The medial column is formed by the first ray. The intermediate column is formed by the second and the third rays, and the lateral column by the fourth and the fifth rays. And when we talk of the foot, we talk of the foot tripod, which is the weight-bearing areas of the foot. So on the medial side, this is the medial two sesamoid bones. Mind you, this is not the first metatarsal per se, but it is the medial and the lateral sesamoids which bear the weight under the first metatarsal. On the lateral side, you have the base of the fifth metatarsal, and then you have the plantar surface of the calcaneus. So a normal tripod is essential for normal ambulation, and you can see there from the plantar aspect. There is also the concept of the Lelevier's parabola, and typically the second metatarsal is longer than the first one, although there may be some anatomical variations. So when you talk of column lengths, we must be looking to restore the foot anatomy, and it is so important to have an X-ray of the opposite side if you want to restore the column lengths. So what happens if there is a medial column shortening? So suppose this was a situation where the metatarsal shortened because of comminution. So in this case, you would have a cavus deformity. On the other hand, if there is a shortening of the lateral column, you would have a planus deformity. So the medial and the intermediate columns have very less movement, or the intermediate column has approximately no movement at all. So you want to rigidly fix these columns. On the other hand, the lateral column is very mobile, so we do flexible fixation for the lateral column. And I will be now talking of each of these variants by some case-based discussions. So when you talk of low energy variants, you want to restore the anatomy. The big debate here is whether you fix or fuse. The proponents of fusion say that this is a single stage procedure. There is no need for a hardware removal. And the recent meta-analysis have shown that there is a slightly better functional outcome, which may be debatable. But the proponents of fixation say that fusion is too big a surgery. When you have high-end athletes, you want to preserve as much motion as possible. But the drawback of ORIF is, especially when you are using screws, is that you are violating the joints anyways. So the long-term effects of this thing is not known. And if you do an ORIF procedure, you have to remove the hardware. So here is a case. A 21-year-old male comes into my emergency. The SR, the senior resident, does an X-ray. This is what was sent to me. Doc, is this okay? Should I send him back? I don't see anything. Should we send him back? But the key point here was that he had a twisting injury. There was tenderness over the tarsometatarsal joint. So I said, this X-ray is not good enough for me. Take off the slab and do a weight-bearing view. So for the registrars and the postgraduates who are listening, mind you, this is very, very important. Now, what happens when you get a weight-bearing view? And as you can see here, this is the middle cuneiform. That's the medial border. This is the second metatarsal. That's the base. And you can see that there is a mild lateral shift. There is no other injury. There is widening of the intermetatarsal space. So this is undoubtedly a ligamentous Lisfranc injury. Now the patient was very, very finicky. He was not really convinced that his father was a doctor, so he was not convinced that this is a Lisfranc injury. Although in my mind, the diagnosis was clear. They wanted to go for an MRI. Now, mind you, an MRI may not be available in all setups, but we did have this. We did do an MRI, and you can see the shift is again very, very obvious, even in this non-weight bearing MRI. And then this is the Lisfranc ligament, and you can see a signal change within the Lisfranc ligament, which is indicative of a Lisfranc injury. So the diagnosis was very clear. We planned for a percutaneous fixation in this case. So here we had the facility of a 3D C-arm, which gives you images like an intraoperative CT scan. And again, you can see the shift of the second metatarsal. So in this case, I applied a percutaneous clamp and tightened it. Now you don't really want to compress these joints, but as soon as you tighten the clamp, you can see that the medial border has aligned with the middle cuneiform. The Lisfranc joint is reduced. Again, this is confirmed on our 3D C-arm. And then you fix this with a Lisfranc screw. Dr. Vinod Panchbhavi from the United States is a proponent of putting it like this, which I've started doing. This case was done almost 3 years back. And once you've put in your Lisfranc screw, then you stabilize the second tarsometatarsal joint. Now, what about the first ray? So I did a stress test in this case. You apply a plantar and an adduction moment to the first metatarsal, and you can see here that the joint does not become incongruous. Now, this is a different case to your right-hand side, and you can see as we apply a stress, the joint lines have become incongruous, and there is a frank dislocation of the first joint. So this particular case did not show any instability and did not require fixation of the first ray. So this is the final fixation. I'm sorry, I don't have the final follow-ups, but the 2 years he's gone to Canada. This person is doing well. His screws were removed at 6 months post-operatively. So in fact, we did publish on percutaneous fixation of Lisfranc injuries. This is how we position the patient. We flex the knee, put a bump under the foot to have easy access. The first step is proximal fixation. So if you have intercuneiform instability, fix that. Go in a proximal to distal direction. The second step is to put in your Lisfranc screw, like I've already shown. Secure the tarsometatarsal joint. And then if you have first ray instability, you address that. You also check for the intermediate and the lateral columns. And if you have instability, you address that. So what are the other options? Now, people have started coming up with the Lisfranc tight ropes. We don't have access to this at the moment, but this is something we would be wanting to do in future. Of course, cost is a concern here. Now, this is a very interesting article from Zwip and Remelt et al., where they have described anatomical reconstruction. And these authors use half of the extensor hallucis longus tendon. They have also described reconstruction by means of the extensor digitorum brevis tendon. So now a representative case from the high energy variants. So the goals of treatment are more or less the same, but the important bit here is don't miss the proximal instability, and I will show you this by means of a case. The big debate in the high energy variants is whether you want to put in screws or bridge plates. So the advantage of screws are that you can do this percutaneously if there is minimal displacement. The removal is easier. All you need are stab incisions. But then if you leave the screws in situ, they have the propensity to irritate. And if you leave them for long enough duration, they can break, and this can be problematic. Bridge plating has come up in a big way over the last 10 years. It has the advantage of not damaging the articular cartilage. You can use it for comminuted cases, but then when you remove it, it requires a full exposure. So this is a 36-year-old male with road traffic accident. He had an associated tibial fracture, and this was a 3 weeks delayed presentation to us. So the plan here in this high energy Lisfranc was to do 2 incisions, and since it was a bad instability of the first ray, we decided to do a fusion of the first and the second rays in view of the delayed presentation and flexible fixation of the fourth and the fifth rays. Of course, the metatarsal fractures also need to be addressed. So this is how you do your medial approach. I will not go into the details, and that's the incision for the lateral approach. This is the medial window. Very good visualization of the first and the second complex. And then this is the lateral window, which allows you access to the third and the fourth metatarsal bases. Now, in this case, the third metatarsal was comminuted, so a bridge plating procedure was done. And as you can see here, the first ray has been stabilized with 2 screws and a K-wire. The first metatarsal articular surface is really big. So sometimes a single screw is not good enough. An intercuneiform screw was done to, address the intercuneiform instability. And then because the second and the third metatarsal bases were comminuted, bridge plating was done. So this is the 6 weeks follow-up. The K-wires were removed at around 2 months. This is 6 months. And then you have the 1 year follow-up, whereas everything has settled down. It has consolidated. The scars have healed well. And then this is the final follow-up of the patient. So he's doing well, although he's a slightly, a bulky guy, but he has no pain and he's able to do everything very comfortably. So here is another case, Lisfranc injury. My senior resident thinks that this is a standard Lisfranc, but mind you, this is not. If you see this, the medial cuneiform is comminuted. The CT scan confirms the comminution of the medial cuneiform. And mind you, this is a very, very unstable injury. And let me show you the intraoperative image in this case. So you can see here, even with a very minimal sort of force, the whole medial column is displacing, and that's the kind of instability in this case. So in this case, as I told you earlier, a bridge plating procedure was done. So we bridged across from the metatarsals into the navicular and also addressed the intercuneiform instability. The other rays were okay, so we left them as such. So moving on to the third part, the neglected injuries. So this is a 35-year-old male who had maybe a subtle Lisfranc injury or, maybe something more than that, but the initial x-rays were not available to me. And he comes into the outpatient with this kind of an x-ray, a frank Lisfranc arthrosis. But then the idea of showing this case was this was not the only problem. He also had a metatarsal malunion. So if you look at the 3D anatomy of this case, the arthrosis is pretty much obvious, but there is the malunion of the second metatarsal, it's going into a varus position and plantar flexion, and that actually was causing him pain. He had pain right under the second metatarsal head. So this is how he walks, very antalgic gait. And the thing that we have noticed is that because they have medial column arthrosis, they tend to walk on the lateral border of the foot, and then you will see that the cavus or the medial arch is more as compared to the normal side. So this is a very consistent finding when you have medial column arthrosis. So the plan in this case was, of course, to do a fusion, but also to restore the second metatarsal anatomy. So this was the standard exposure. All the joints have been exposed, and this is a little bit more exposure than the operative fixation because you want to prepare the joint surfaces between all the metatarsals in the first and the second row, and also between the Lisfranc articulations and the cuneiform articulations. So in this case, fusion was done by means of screws. We got very stable fixation and compression. Then we moved on to the metatarsal osteotomy. So an osteotomy was done. The shape of the metatarsal was restored and it was fixed with plate. This is the 3 months follow-up. And again, I'm really sorry, I needed to have the final follow-up. The patient was due to come in, but because of the COVID restrictions, I cannot show you the final follow-up, but he's doing fine. He's walking around painlessly. So to sum up this talk, all Lisfranc injuries are not the same. We have talked about the low energy and high energy variants. So the important bit about the low energy injuries is don't miss them. Please look at the x-rays very, very carefully. Fusion versus fixation is a big debate, but if your patient is on the younger side, they demand more mobility, fixation is the way to go. If they are slightly on the older side, obese, and you want a one-stop procedure, fusion is the way to go. High energy injuries are easily diagnosed, but then you have to address them well, restore the joint anatomy, restore the column lengths, and don't miss the proximal instability like I've showed you. Neglected Lisfrancs, again, fusion is a very straightforward procedure with very rewarding results. But like in the case I've showed you, do not miss associated foot pathologies or else you will not have a good outcome. So thank you for giving me the opportunity to present this talk. And this is a very interesting article that we published in the Journal of Emergency Medicine, especially for the postgraduate students. This talks about the subtle findings of the ligamentous Lisfranc injury. And please drop me a message if you need the full text of this article. Thank you so much. Thank you.
Excellent presentation, Siddarth.
Thank you.
So I think he has made himself the topic very clear. So we move on to the next talk by Dr. Mohammad Farooq Bhatt, who is a faculty in GNC Jammu, on coronal shear fractures of distal humerus.
Good evening, sir.
Farooq?
Good evening, sir. Can you hear me?
Yes, please.
There was a problem connecting, basically. Now,
can we start
Can
your
you
screen share?
can you see this?
Can see you.
Can you see the
Yeah,
presentation?
just rotate it. Yeah, it is
Yes.
visible.
Presentation?
Mhm.
Sir, are you able to see the presentation? I have some problem connecting my desktop.
It's tilted actually. You need to rotate it 90 degrees. Yes, it's better.
Yeah, that's better.
That's better.
You're able to see, sir?
Yes,
You're able
please.
to see?
Yes, yes. Go on, please.
Yes.
Okay. Good evening, everybody. Sorry for brief problem with the laptop. It is not connecting. I am presenting coronal shear fractures of the distal humerus. At the outset, I would like to thank my teachers at the Hospital Bone and Joint Surgery, Srinagar, who first introduced me to this fracture way back in 2001. These are very rare injuries, but complex and challenging, involving either capitulum or trochlea or both, and they occur in all ages. And in elderly patients, we do have comminution. Almost all of these fractures are displaced. Incidence is higher among women, and they are always associated with some injuries, most commonly lateral collateral ligament injury and radial head fractures. Most two potential mechanisms have been described resulting these injuries. One is the direct axial loading at capitotrochlear area, where the force is transmitted through radial head, resulting in capitulum, trochlea, or fracture of the both components. Second mechanism is fall in on outstretched hand with the elbow in extension, which results in failure of lateral collateral ligament and posterior lateral subluxation of the elbow. During spontaneous reduction of elbow, there is shearing force via radial head and coronoid at the capitulotrochlear area, which results in these fractures. There are many classifications described. Brian Morey's classification basically addressed the capitellar part of it till Mackey realized that it is basically extending into the medial lateral part of the trochlea as well. But the best classification is Debrulli's classification, which not only took capitulum and trochlear components into consideration, but also divided it into subtype A and type B, depending on presence of metaphyseal comminution. And Watson modified this classification. He added type 4, where we have multiple sagittal and cornal plane fractures, resulting in multi-fragmented, comminuted, difficult fractures of distal humerus. In clinical evaluation, one has to be suspicious of these fractures because they are often, in females in particular, low energy trauma. There has to be high index of suspicion, and assessment has to include to exclude instability, and we have to assess concomitant injuries, and of course neurovascular examination. Plain radiographs are insufficient in assessing these injuries, and various views may help us in knowing a few more things about them. But plain X-rays historically have been having low sensitivity in diagnosing these fractures. So a simple fracture on X-ray may turn out to be a complex one on table. And AP X-rays are very deceptive. They hardly give any information about these fractures. And there are some signs: half moon sign, double arc sign, and triple arc signs. And the presence of these signs means that the surgeon is going to have difficulty during evaluation and fixation of these fractures. Because radiology X-rays are insufficient in dealing with these injuries, so you should have low threshold for getting a CT scan. And 3D CT scan has a profound effect on our understanding of these fractures and planning surgical approach and implant choice, because it is because of CT scan we are able to get into the details of medial extension of these fractures, articular impactions, metaphyseal and condylar comminutions, and ruling out other concomitant injuries. MRI doesn't have a clear established role unless it is indicated in those patients where CT is contraindicated. Treatment options are range from non-operative to elbow arthroplasties. Close reduction is of historical importance. It is no longer recommended in view of the excellent knowledge that we have gained over a period of time and the choice of implant that we have. Fragment excision was in fact the first treatment that was published in 1934 for these fractures, but it is very rarely done and is restricted to only excision of few osteochondral fragments. Open reduction and internal fixation present is the primary form of treatment, and surgical approach depends on the complexity of injury. Part of the fracture involved, the capitulum or trochlea, both are involved, comminution and associated fractures. Extensile lateral approach is the most commonly used approach. It gives good exposure for isolated capitular fractures and type 4 capitular fractures without any additional risk of osteonecrosis of the capitulum. Anterolateral approach is also very commonly used and depends on the surgical skills of the operating surgeon and how comfortable he is in approaching these fractures, particularly the lateral part of trochlea involved. This approach can be utilized along with fixation of the capitulum. Olecranon osteotomy approach has been used for medial extension of fragments with significant posterior comminution. And there is no significant difference in outcome between extended lateral approach and this approach. And olecranon osteotomy approach is used once we have medially placed fractures. And standard medial approach can also be used for accessing these fractures. We have found anteromedial approach as a useful approach for accessing isolated trochlear fractures, but one has to be careful during retraction because one of our patients developed paresthesia in median nerve distribution, which took almost around 6 weeks to recover. This is an intermediate approach wherein we have an interval between triceps and brachialis proximally and peroneal teres and brachialis distally. And we can have an excellent view of trochlea, and it can be fixed with headless screws. Other approaches have also been described, wherein surgeons have used two incision techniques. They have combined medial and lateral approach. As far as implant is concerned, as our knowledge about the fracture anatomy has improved, and CT scan has really helped us in knowing the exact anatomy of these fractures, implant quality has also improved over a period of time. When we first published our result in 2004, it's 2004, not 14, we used in three cases, we used only K wires, and hardly we had any access to these headless screws at that time in 2004. But now we have better implants available for fixation. Independent screw fixation is the most commonly used method, and this is appropriate for simpler fractures, doubly type 1A and type 2, where there is no posterior comminution or bone loss. But there is scanty literature on the use of optimal screw types and screw directions. Algovis did a cadaveric study in two parts, comparing the AP and PA fixation with 4 mm partially threaded cancellous screws, and concluded that PA directed screws displaced less on cycle loading. But splits were identified in articular surface with AP screws, primarily because of the larger diameter screw used and the force that was required to bury the screws. And he also compared AP headless screws with PA cancellous screws and concluded that AP headless screw fixation was superior in terms of both cyclic loading and load to failure. And AP screw placement reduces need for posterior dissection and respects the capillary blood supply. Pre-controlled locking plates have also been used, as is used in double subtype B fractures, where plate is used to create a posterior cortex through which posterior entero screws are placed. Anti-glide plates are also being used for highly unstable fractures with no anterior periosteal hinge. Biabsorptional implants are used for securing osteochondral fragments, but they are not routinely used in case of adult coronal shear fractures. Implant fracture and reactive synovitis have been noted with the use of these implants. And these osteochondral fragments can also be fixed with the help of sutures, where tranche osseous tunnels are created and a knot is applied posteriorly for securing these osteochondral fragments. Arthroscopy has also helped in fixation of simpler type of fractures where you have good visualization of these fractures, but it needs high level of skills to negotiate through small tunnels and fixing the screws with screws. Total elbow arthroplasty has been reported to be helpful in elderly patients with comminuted fractures where there is poor bone quality and rigid fixture is not possible. This is an algorithm based on WLE's classification wherein one can easily choose that approach and type of fixation device depending upon which type of fracture a surgeon is dealing, whether it is subtype A or subtype B, and this can help us in making a rough assessment of the approach as well as choosing the implant preoperatively. Post-operative care also depends on the surgical techniques, the type of fractures, the type of fixation. If there is optimal fixation, early exercises can be started. But if the fixation is suboptimal, the limb has to be supported in a functional brace, or delayed mobilization has to be started. Outcome is this good to excellent outcome with ORIF in most patients, but also depends on the fracture. Simpler fractures have good outcome. Fractures with comminution and poor bone quality and poor fixation have got really bad outcome. We have found stiffness and osteonecrosis as most common complications in our cases. But stiffness, in one case, we did do an anterior capsulotomy to address the flexion deformity that the patient developed. But there are always not dependent on the fracture also. Techniques have to do malplacement of screws, bad placement of K-wires, and bad planning can also have bearing on the outcome in these patients. In conclusion, these are really uncommon injuries, but they are challenging. CT scan is highly recommended for preoperative assessment. This helps us in planning the approach and type of implant that we can use, and we can predict from that how good the outcome is going to be. Open reduction with headless AP headless compression screw is a treatment of choice for simpler fractures with good to excellent outcome in most cases. Thank you.
Thank you, Dr. Farooq, for the talk. Now, can I invite Professor P.N. Gupta for his talk on how pediatric injuries are different from adult injuries?
Good evening, friends. My talk is very, very simple, and I'll be discussing about how the children's fractures, how they are different from the adult fractures. I think you are able to see my screen,
Yes, we can.
Dr. Sanjeev.
Yes, sir, we are able
Okay.
to see.
So pediatric fractures, they are basically common, but they have a good union rates as compared to the adults. The treatment is relatively simple. Only thing is that we need to identify the injury correctly. So what are the basic differences from adult fractures? The mode of injury is usually different. The bone morphology is different. That means the fracture patterns could be different. The management is different, and the complications are also different from the adults. And please remember that the children are not mini adults. They have a different anatomy, different behavior of fractures. So let's see what is the mode of injury. The common modes of injury in children are basically injuries from unorganized sports. That means fall while playing, uh, fall while jumping, or fall while cycling, and they are basically low energy injuries. High energy injuries, including vehicular accidents, are uncommon. Industrial accidents are highly, highly uncommon, very rare. If in case, I mean, there is no child labor as of now, as I understand in India. And firearm injuries are very, I mean, unheard of. Farm injuries sometimes, especially the toka injuries, are common in the villages. So basically in children, the most common mode of injury are the low energy injuries due to fall and injuries from unorganized sports. The bone morphology, if you see the bone morphology in children, the pediatric skeleton is unique because it is a growing skeleton with constant remodeling and relatively weaker bones. So that means a less severe trauma can cause a fracture. That means fall while playing can cause a fracture in children, and it is highly unlikely to cause a fracture in a young adult. So all these injuries in a growing skeleton can be like this injury is because of the twisting injury, fall while playing, and this is not heard of in young adults or even in older adults. So injuries, they will occur at the weakest link, and the weakest link in children are not the ligaments as compared to the adults, where the ligaments are one of the weak areas, and of course the where the force is directed. So in children, the ligaments are relatively stronger than the bones. So strains and sprains are highly uncommon in children, and fractures are much more common in children. So what are the anatomic differences? In the, if you see the region in the adults, you have the diaphysis, metaphysis, and the articular surface, whereas in children you have the growth plate or the physis and the epiphysis. So these are the growing ends of the bone, And any injury to the epiphysis or physis can lead to potential complications, which we will be discussing later. So epiphyses at birth, most of the epiphyses at birth, they are completely cartilaginous. As you see, this proximal femoral epiphysis is completely cartilaginous. And secondary ossification centers appears during the various ages in the period of the child, and these secondary ossification centers are replaced by bone at skeletal maturity, and this is one secondary ossification center of the proximal femur, which usually appears around 6 to 8 months of age, and eventually that fuses with the main femoral neck. So what is the importance of this? If you see this X-ray, it shows, perhaps you can pass it as normal or you can pass it off as some displacement there. But this child, if you see at 2 weeks, you will see that there is a lot of callus formation. So one has to be beware of invisible fractures. And where do these invisible fractures occur? Through the unossified bones. And this is another example of a fracture occurring through the unossified bone. And this sort of injury is often confused with an elbow dislocation. And this tends to present at a stage of around 2 weeks, when usually the parents will notice a swelling. And this is basically a callus formation. So please be beware that bone failure occurs earlier than the ligaments in children. And one also must be aware of that even in the epiphysis, if it appears to be small, especially in the younger children, there is a lot of unossified cartilage attached to it. So this sort of injury is not an epicondyle injury, but a condyle injury. And if you miss this fragment of condyle, this can lead to later on problems with the elbow joint. Physeal injuries are peculiar to children, and physeal injuries are basically 15% of the total pediatric fractures. And they could be extra-articular physeal injuries, which are basically Salter-Harris type 1, or physeal separations, or Salter-Harris type 2, which include a spike of the metaphyseal fragment or the Thurston-Holland fragment. Intra-articular are Salter-Harris type 3, where a part of the epiphysis is fractured, and this injury doesn't extend into the metaphysis, and the type 4 extends into the metaphysis. So these are intra-articular injuries, and all intra-articular injuries in children should be anatomically reconstructed. Otherwise, they can lead to later on degenerative arthritis. So another important aspect of the growth plate injuries are high chances of physeal arrest, especially in Salter-Harris type 3 and type 4. And second thing is that intra-articular step may lead to premature arthritis. So accurate reduction, sparing the growth plate is essential, like for this fracture of the so-called medial malleolus in children. One can consider compression screws, sparing the growth plate. And if you need to cross the growth plate, you should always do it with smooth wires, not with the threaded screws. Like on the lateral side, there is a physeal separation of the distal fibula. So it has been crossed with a smooth wire, not with a threaded screw. Second thing is why anatomical reduction is required, that if you don't do it, there can be a crossbar formation between the metaphysis and the epiphysis, like this sort of thing. So if this reduction would have been accurate, there would not have been a bar formation. So do not cross the growth plate with the screws. If you need to cross, use smooth K wires. We have discussed it already. And second is important aspect is that the physis should not be confused with the fracture. So this is the physis or the growth plate. This is the growth plate, and you can appreciate a fracture there, and this is the fracture. But this is the growth plate, so they should not be confused. Diaphyseal fractures could also be a little different, and you could have plastic deformation, and more so in the ulna, it's very common. And if you miss this plastic deformation, this is actually a Montegia fracture dislocation. And you can see that the line passing through the long axis of the radius is not bisecting the capitellum. So this is anterior dislocation of the radial head and plastic deformation of the ulna. Buccal fractures are also common in children, which are basically compression failure due to axial force and usually occur at the junction of metaphysis and diaphysis, common in the distal radius. They are inherently stable, so just need to immobilize them. And green stick fractures is basically the bone recoils back in the deformed position, so bone is bent on the tensile or the convex side. So what you need to do usually is to break this and complete it and to make it into a complete fracture to have a good stability. So what are the differences in management? The union times are fast, union rates are high, casts are well tolerated, rigid immobilization is not, rigid fixation is rarely required, and relatively weaker implants will do the trick. And then even if it malunites, there is a potential for remodeling in some of the fractures. So this is a child with a birth injury, and at 2 weeks, see the amount of callus, and I'm sure nobody will see this callus in an adult situation. So union times are very, very fast. The younger the child, the faster is the union time. The casts are well tolerated, and if you see this both bones fracture in a child, this has been close reduction and casting has been done, but you will rarely see such sort of situation in adults. And most of the times, people tend to go in for interlocking nail, and even for femoral fracture in a child, one can consider a hip spica, and a hip spica in an adult person is unimaginable. So casts are very well tolerated because of the small because of the small child, and second is that the union time is fast. Less rigid implants, as you can see in this distal humerus fracture, this is the accepted norm in children, but in adults you always use a rigid and a more stable fixation. And similarly in forearm you can consider intramedullary elastic nails or K wires, whereas you never consider that in adults. More stable or rigid fixation is considered in adults. Another example, in the femur, you can consider elastic nails. I mean, they are the treatment of choice in little older children, but never in adults where you have to go in for interlocking nail. Potential for remodeling is fast at growing ends and usually in the region of knee and shoulder and the distal radius, and depends on the age and depends on the angulation, where the angulation is. So angulation in the plane of deformity remodels, torsion does not remodel usually. So potential for remodeling in the distal radius, if you see, this is a mal uniting distal radius with about 30 degrees of angulation. And what we did was just immobilized, and you see that at the end of 6 months, it's it's trying to remodel, and it will eventually remodel into a normal situation. Whereas in adults, if you have a malunion, this is not likely to remodel to any extent. Differences in complications, because primarily because of the growth arrest, and angular deformity and shortening could result. Angular deformity if there is a partial growth arrest, shortening if there is a complete growth arrest. So you can see some examples. This is partial growth arrest leading to angular deformity. This was a complete growth arrest of the distal femur leading to shortening. Sometimes you can have growth stimulation, especially in the proximal tibia, and a lot of these children, they could end up in a little valgus, and this is called Cosen's phenomena. So you have, especially in the younger child. So this is a minimally displaced fracture, well reduced, and the child has ended up into a little valgus, and you have to forewarn the parents that growth stimulation can occur, especially in the proximal tibia. So To conclude, low energy injuries are common in children. Usually, the treatment remains non operative or with less rigid implants. One has to recognize the peculiar injuries in children, especially physeal injuries, and their associated complications should also be recognized. Thank you so much. I'll be happy to answer any questions if there are.
Thank you, Dr. P.N. Gupta, sir, for excellent talk. Now I'll move on to the next talk on unicondylar knee replacement, to do or not to do, by Dr. Rakesh Rajpuru from Calcutta.
Thank
Dr.
you,
Rajpuru,
Sanjeev.
sir.
Yeah, thank you very much. I really want to thank the Jammu Trauma Society, in particular the flag bearers, Dr. Gupta and Dr. Ghani. When Dr. Ghani rang me, I think I just jumped with joy that I've been invited to talk. I think some of you may not know, like I belong to Jammu, though I actually live and practice in Mumbai. I come from a very small village called Basoli in Kathua district. So I think the topic today is the UKR. It also looks like a very different topic to the current chain of events which are being discussed today. So I'll just straight away go. And the reason I think I want to talk about UKR is it's something not very well spoken about in different parts of India. And we have taken on the mantle of taking this to the other areas where it's not been that popular. And just want to dispel some of the myths along as we go, as to we should or we shouldn't be doing it. The proverbial question. So if you have a medial compartment osteoarthritis, the general question is, what do I do with it? So the choices so far with, like this is a 44-year-old guy, you might have that, I might go for a, high tibial osteotomy. Then the question arises, do I go for a lateral closing wedge or a medial opening wedge? Or is it a dome osteotomy? Do I use a plate to fix? Do I use bone grafts? Do I use fixators? So there are a lot of things you can do. And I fully agree that this is a very good operation in armamentarium. So the trouble is that if you do this, you have to do it really well, because if you don't get it right and the patient ends up needing a TKR very soon in his life, then you can see from these different papers that the complications of doing a TKR as a revision from a high tibial osteotomy is quite serious. You're looking at high risk of infections and also neurovascular injuries and skin complications. So you got to be really very sure that you've done a high TO properly. And in fact, as we've seen from some of the trauma talks, you got to be fixing things very well. So long time ago in 1970s, the Oxford knee was launched. And these are the results which I'm quoting at 15 years and 20 years survivalship. These are being published in late 90s. So these are not today's results, but these were results from before. If you look at these series, and if you look at the last bottom slide, bottom part of the slide, where David Murray 98 was publishing his series at 10 years. And just above that was the Ben Squire series. Now, Ben Squire was from Bristol, where I was training at that time. I actually joined Bristol in 99. So this paper was published at that time. So we actually were not doing just the Oxford. We were doing many of the knees. In fact, St. George's Sled was our common unicompartmental knee. And look at the results. So it wasn't as good as Oxford, but then we are looking at 22 years results. So if you look at 22-year results, 84%, I think it's pretty good. So overall, many people were doing it actually at the even 90s, and also getting it quite well, to such an extent that the Swedish registry, which I think we regard as our Bible, who actually said that UK is a safe procedure, good patient satisfaction, good relief from pain, and very few serious complications. So way back in 98, it was being spoken about. However, we in India were never even thinking about UKR during those days. So if today or little bit ago, if we had a choice as to do a high that it's not a good operation. So do we have a direct comparison between these two studies? Let me know if my net is a bit unstable. So if you look at all these studies which were done, and the Wheel and Newman series actually is from Bristol. I used to train with John Newman. So even during those days, they were actually quite clearly saying that in good centers, the results of UKA is far superior to an HTO. And remember, Newman was a very good surgeon, even doing a lot of HTOs. So even in his hands, the results of UKR were very much superior. The question is unicompartmental arthroplasty that innocent that we actually start promoting this to everybody? And the answer is no. And in Lindstrand 2000 in his paper actually very clearly said a bottom line, it is a demanding procedure and needs special expertise. To such an extent that the Oxford people were also led to rethink, and then they came up with this criteria that who should be doing UK. And I think the criteria which they actually said that you need to ultimately aim towards 20 to 25% of your practice of arthroplasty knee practice, aiming towards an unicompartmental replacement, and you should be doing minimum 20 in a year. Below that, your results are going to be compromised. Now, if you want to choose in this day and age between a UK and an STO, I think you can vary compared to what your expertise is. But if you have a younger patient, less than 65, probably STO would be your wearing. Similarly, if you have somebody more than 55, but in between them, you could probably go both ways. Similarly, if you have a very high demand patient, you might veer off towards an STO. But remember, I think more than any of these criteria, it's the bone-on-bone contact which matters most. Once you get a bone-on-bone contact, then there is not really a much you can do in the shape of a STO. Also, if you really don't have much deformity, again, then your STO will not really take away too much of the pain in that patient. So be very careful about subjecting any patient to one or the other operation. Next comes, why do we really think that the unicompartmental replacement is so good in function wise compared to an HTO or also compared to TKR? And the answer for that is this kinematics. If you look at the patellotibial angle, which is the angle subjected by the patellar tendon and also the long axis of tibia, and if you plot this graph in different ranges of knee flexion, and you're looking at from 0 to almost 100 degree of flexion angle, this is the normal angle you would find in a normal patient. If you look at a TKR patient, you would see that the curve is almost like a small plateau. It's not even horizontal, small plateau, far different to the curve which was made by the actual normal knee. Now, if you look at the actual curve being made by a UKR at 1 year, you see this almost resembles the actual normal knee kinematics. The same curve, even at 10 years, if you see, it is again the same incline as to a normal knee. So a UKR even at 10 years is functioning the same way as a normal knee, normal non-replaced knee would be functioning. And I think that is where the actual beauty of this operation lies. Also, I think what we got to look at is that in days gone by, when there was a lot of fixed bearing surgeons, particularly in the US, were talking about, there are some contraindications to knee replacements, and they came up with contraindications of patellofemoral joint damage, age, high level of activity, obesity, chondrocalcinosis, and lateral damage. Now, this was the criteria which we actually label as Cosin and Scott criteria. And if you use this criteria, majority of your patients actually then will become non-suitable or unsuitable for actually going through a unicompartmental replacement. Now, when they are critically analyzed, the first one to be analyzed was the patellofemoral joint. Now, Goodfellow, in his series of hundreds of patients, when they actually published, they found that in their revision rates, not a single patient was changed due actually patellofemoral joint. So in their summary, they said patellofemoral joint does not matter. Now, if you actually do not ignore this, you will be a lot of patients you would actually not be doing this. So be very careful about patellofemoral joint arthritis, which looks on the X-ray. Then the next case question comes when you open it up and you see a full thickness cartilage loss, or FTCL as we call it. Now, if you have even on the medial patella or on the lateral patella or on trochlea, these do not compromising the actual outcome. So they are not a contraindication to actually unicompartmental knee replacement. Now, when you do a skyline view to look at the patellofemoral articulation, even if you see bone-on-bone contact on the medial side, that is not a contraindication to UKR, because as soon as you do UKR, you will decompress this area. However, the same thing if it happens on the actual lateral side, then you probably are a bit skeptical about doing these cases, particularly if you see bone-on-bone contact on the lateral side. These cases, perhaps nowadays we agree that should not be undergoing a UKR and probably are better suitable for a TKR. Now let's come to the age. Now, before it was said that, when you're older, don't think about UKR. UKR is for young, active, fit patients. Older patients, you should actually be subjecting to a TKR, one operation, sweep the broom and do one surgery. Now, I would actually argue to the contrary that elderly patients actually do not tolerate a TKR very well. Many of them are diabetic, very severely diabetic, so the chances of infections are high. Having lots of previous operations which might have been done on the knee. Also, many of these patients are very compromised cardiac-wise, and you might come across many of them having ejection fraction between 40 to 50%. So they are very especially unfit and very low morbidity and very high mortality cases. So we have understood that young is not a contraindicated. Similarly, and what I'm arguing is even the older patients are not a contraindications. As you see on the slides on your right, the success rates for both the groups is pretty high. Now let's look at the high level of activity. And the Oxford group, when they look at high level of activity, is the Tegner scoring they give you. If you can really jump around, if you can, do all sports, skiing and all that, you would be graded as Tegner 5. And if you would be just doing casual sports, you would be Tegner 1. So in between this 1 and 5, you have lots of scoring systems you can give. So even in these high activity groups, if you see the Oxford survival group, it's quite high. So I think the more you actually find activity level of patients, the more a UKR will actually perform better compared to a TKR. However, if the patient is suitable for a high table osteotomy, I think that might be the operation recommended for these patients. Next, the one we actually want to talk about is the obesity. And it was spoken about that if you are obese, then UKR is not the operation for you. I came back to India in 2005 and actually met this gentleman in 2006 who's just standing with me in the picture. Now, this guy used to weigh 148 kilograms when I first met him in 2006. He's actually lost 20 kgs. And he is very proud to say that he is now, around 138 or something, 130 kgs. So this is his daughter getting married. This is last year. So from 2006 to last year, which is around 14 years, survival of a fixed bearing unicompartment knee replacement in this obese patient. And this was my index patient. So, I was just getting used to the fixed bearings scenario in India. And even if you look at the Oxford series, up to BMI 45, the results are exactly same. Of course, they are slightly lower compared to if you see the results of non-obese patients, but that is the same scenario with a TKR patient, that your scoring or the Oxford knee scores will be slightly lower for however, the survival rates are actually quite good. And the reason for that is that these patients hardly do anything. So their knees actually survive a lot more. So obesity, again, is not a contraindication. The another contraindication in the Cosin and Scott criteria was the chondrocalcinosis. Now, again, a lot of these patients have had the operation done as a UKR, and it's not been found to be a contraindication. So I think the ideal criteria for a UKR or the unicompartmental knee replacement or partial knee replacement would be an anteromedial or a central osteoarthritis where there's a bone-on-bone contact. You have a functionally normal ACL for the mobile bearing TKR. However, you can do a UKR even if you have no ACL, but then you should probably be opting for a fixed bearing UKR. Functionally normal MCL, and this will happen if you have only anteromedial arthritis. And even if you have full thickness lateral defects, that is not a contraindication. And definitely not a contraindication is patellofemoral joint, anterior pain, chondrocalcinosis, obesity, higher age or very lower age, or activity levels. And examples of them are here. This is a 41-year-old guy who came to me in 2008 with a medial joint arthritis. And at that time, when I did his x-rays, this is a standing view. So at that time, I gave him all the options as to what he wants. And these are stress views, and you can see this clear-cut bone-on-bone contact. However, on stressing laterally, there is good lateral joint space. So at that time, even I was also offering high table osteotomy to these patients also. However, he listened to all that. He is not a very active guy, but does do a lot of walking. He agreed to actually go for a unicompartmental knee replacement. That's what we did for him. And at that time, he had asked me, when do I need a revision for this? And I said, about 10 years later, you will probably need it. So here he's back to me 10 years down the line, actually has come for revision without having any symptoms. So I said, what is your problem? And he said, well, you had said 10 years later, I need a revision. So that's him giving us an opportunity. Now he's 51. And that's him walking down the stairs and on the treadmill. We've raised the tread ball even up to the level 7. So that's him. And you can see how active this guy is even 10 years down the line. The next is a 74-year-old male, again having medial joint space. And look at this, the profile of this patient. The reason he's wanting an operation is because he's not able to play golf. Now, these are the typical patients you would see in a UK or a USA group, but we would normally not see them in India. However, this guy is an ex-army guy and very, very fit guy. So when he was offered a knee replacement by other doctors, he actually asked them, can I play golf and can I bend down and actually look at the tee? And they said, well, you can't do that. So when he came to me and I said, if you really want to do that, then the partial knee replacement is the way you go. So that's what we did for him. Again, look at the activity levels of this guy. He is now 3 years down the line. So he's about 77, and see the activity level of this guy. Now, this guy will never be happy if you actually offer him a total knee replacement. Now, my last case, which I'm going to show you today, is very recently done one, 91-year-old orthopedic surgeon. Now, he's the oldest living orthopedic surgeon in my city. Now, that's his knee. He's fed up of his life. He is now wheelchair bound. For the last 50 years, been a surgeon in a university here, and he actually has come for an operation. However, when you examine him, you realize that he's got a lot of defect in his medial side. There is a slight medial pseudolaxity. On top of that, he is diabetic, quite severely diabetic, on insulin. He's had 2 MIs. His ejection fraction is 30%, and he's also hypertensive with mild CKD, which I think at 91, you wouldn't be totally surprised. Now, with this profile of a patient, how risky would it be for a total knee replacement? So we counseled him. He's given a consent for everything. And I said that I'll try my best to get away with a UKR. Now, these are ideal patients for UKR. The surgical trauma for 3 UKRs is equivalent to 1 TKR. So I think in these cases, you should try your best to actually get away with a UKR. So that's what we have done. I don't think if the X-rays are well seen here, but that's his patient. He's a very new one, so I can't show you his mobility. But I think what I would like to say here is that the partial knee replacement or UKR is here to stay. And I really request all orthopedic surgeons actually should try and venture into it and learn it. However, I think what recently we have done is we started doing UKRs from using robots. And worldwide, I think this view is coming into picture that the robotic UKR may become the operation of this decade. And I think with this, I would again like to thank JTS and thank everybody who's listening. Thank you.
Thank you.
Thank you so much, Dr. Rakesh, for an insight into the less talked about topic in orthopedics, which is a uni knee replacement. So that ends with this talk ends the whole session now. Can we have any comments from the speakers, if any? Any comments from the speakers?
Sanjeev, can I ask a question to, I quite like that talk on Liz Frank. I think it was Siddarth, is it?
Yes, please do.
I don't know him well, but I was quite impressed with that talk.
Thank you.
Siddarth, very nice talk. Some of these Liz Franks also come with compartment syndrome. How often do you see in your scenario? Because I think people in Chandigarh come from referral centers, so they're a bit late. But do you come across this compartment syndrome in your hospitals?
So, sir, compartment syndrome of the foot is an enigma. And to actually diagnose one is very, very difficult because the clinical criteria for this are not so well defined as, compared to compartment syndrome of the leg. And about 3 years from now, we were a little more aggressive with the compartment syndrome of the foot. So anytime you had a massive swelling, or loss of sensations, and especially with high velocity injuries, we would go in and do a fasciotomy. But soon to realize, so because everything evolves, your learning evolves, soon to realize that if you've done a fasciotomy, you messed up your incisions for future fixation. Now you cannot do a definitive fixation when you've done a fasciotomy, and those incisions are going to really trouble you later on. So my chief is Professor Mandeep Dhillon. He is a very experienced foot and ankle surgeon, and these days we rarely, if ever, do a fasciotomy. And we still are grappling with the concept of the compartment syndrome of foot because the literature on this and the experience on this is very limited.
Agreed. I think I have not actually myself come across a very suitable answer to this question, and even to diagnose it actually on table. One more question to Dr. Gupta about the pediatric injuries.
Yes.
You showed quite a few very young patients, particularly around elbow. Do you also use arthrograms to diagnose these injuries? Because even X-rays are actually not going to show up all of it, particularly very younger patients.
Yeah, I agree with you that, see, issue is that a lot of times these injuries are missed. And what they come is around 7 days down the line with the callus. And at that point of time, you really don't need to do anything. The good point about these injuries of distal humeral physeal separations are that most of the time they remodel even in the coronal plane. So yes, if it is very, very young, I have done in 2 kids only till now. They presented on the 2nd day, so we did a close reduction in both the kids and they're doing well. But I agree with you that arthrogram is indicated if you need to reduce. Other imaging modality is the ultrasound for diagnosis, but not for management, especially in the proximal humerus. You can consider ultrasound, and the proximal humerus, you really don't need to do much apart from the symptomatic treatment, because proximal humeral fractures, by and large, they remodel to, almost fully within 6 months to 1 year.
Thank you so much, all the speakers.
Yes, Dr. Harpal has a question.
Now we'll move to the next session.
Dr. Sanjeev, Dr. Harpal wants to have a comment.
Yes, Dr. Harpal, please go on.
Again, the hot and the important topic is Lisfranc. Siddarth, how do you choose to fix with the screws or with the plates? How
Good
do you
evening,
make the
sir.
choice?
That's a great question. I touched on this partly, sir. So I would tend to use a plate if there was comminution of the metatarsal base. That would be the primary indication. And for uncomminuted Lisfranc fracture dislocations, because cost is one of the concerns here, and if you want to use good quality plates, especially in our patients, cost is a concern. So my indication for using a plate would be the comminuted fracture patterns, sir.
Otherwise, they say if you want to fuse, use a screw, otherwise you use a bridge plate. How many broken plates do you see in your practice? Because you do a lot of footwork, I know.
Yes. So I understood that the question was meant for the open reduction internal fixation. For fusion, whenever I can, I prefer plates, because once you put in your compression screws, the plate acts as an offloading construct. So if I can get a plate for my fusion, I will put it. For fixation, if there is comminution, I prefer the bridge plating. And sir, so far we have not really come across broken plates. But like they say, all things get worse with time. All the follow-ups will spoil all the results. So we may see a few in the near future. Thank you, sir.
Okay, thank you.
Thank you.
Dr. Siddarth, sir, I have a small question regarding your talk. You said about weight-bearing X-rays. So actually in acute setting, what is the feasibility of getting those X-rays? Because we often send the patient when we are in doubt, but we don't know exactly if it's a weight-bearing X-ray has been taken, because it's acutely painful and not so comfortable for the patient also.
Great question, Rashid. So to answer that, if this was a high velocity injury, the patient came in after a road traffic accident, of course you don't want them standing and getting a weight-bearing X-ray. But where it is really useful is for the low energy injuries. So like the footballer who comes in with a twisted foot, he comes limp walking, to your ER. So of course he can weight bear for, for half a minute, and you can get the X-rays. In the other way that some of the faculties that I have heard they do is they ask the patient to sit on a chair, and put pressure on the foot as much as they can. So this is simulated weight bearing. And in the literature, they have also described temporary blocks to facilitate that. But, a middle ground would be if your patient cannot weight bear, the X-rays look fishy, so you are not sure this way or that way. Ask the patient to come in after 24 or 48 hours, let their pain settle down, and then get a weight-bearing X-ray. So this is a trade-off that you can do, but please do not let them out of your sight, because if they are gone, then you've missed the opportunity to diagnose these subtle injuries.
Okay. Thank you, sir.
Thank you, Raj.
Thank you so much. And I think we move to the next session now. Dr. Ghani, can you please start the next session?
Yes, please. So I think Dr. Atul Srivastav is not going to be joining us. So can I ask my friend Dr. Bhavuk Garg to speak on newer advances in spinal injuries, please, surgeries. Dr. Garg, over to you.
Thank you, Dr. Ghani, for giving me this opportunity. So I'll be talking about the some of the recent advances in spine. Actually, spine is quite the changing field, and many a days new and new changes and new advances are coming up. We recently published. I just guest edited this issue of JCOT. What is new in spine surgery, and we have covered many new advances in that. I will be touching upon some of them in this talk. So one of the favorite is my topic is about 3D printed spine surgery. So we know that the 3D printing is an upcoming technology in the field of spine. And if you look at the steps to excellence in 3D printing, they are actually 7. When we start with templating, then we go to 3D planning, then we use the anatomical models, and then we can use for patient specific guides and then patient specific implants. And if we can integrate them with our pack system, then it becomes an integrated workflow in your system. So preoperative planning is, we know as orthopedic surgeons, it is like the dress rehearsal of operation. And we used to do tracing manually in our residency days. But now we have this 3D printed, and you can actually use these sort of jigs, these sort of models, and you can look at the exact diameter of the screws and the length of the screws for your planning. One particular area in which we have found usefulness of these 3D printed models is the complex spinal deformities, especially the spinopelvic deformities, where you can look at the position of the cup as well as the amount of resection of the osteotomy in complex spinal deformities. They also helps you in planning of the positioning of the patient, because these sort of complex spinopelvic deformities, they need a lot of planning to position these patients also, because when you correct these deformities, then also there is a lot of change in the position of the patient. So we also did this paper, which is already received many citations. We published in 2019. We have a dedicated 3D printed facility which I got as an award from the DBT, and we actually take a dedicated CT scan of 0.6 to 5 millimeter axial scans, and we import these CT scans to the Mimic software, and we isolate each and individual vertebra which we are going to fix in all the planes. This is a very tedious process, and then we virtually isolate each and individual vertebra, and then we project these cylinders which actually denote our future screws into these vertebrae. And then we, with the help of the reverse 3D printing or the rapid prototyping, we develop these jigs, and then we validate these jigs virtually. We place these jigs on these virtual models, and then we confirm their validity. And once we have confirmed their validity, we print them, and then we again check their validity on a physical model. And then once we have confirmed their validity, then we are ready for the surgery. It's like this is a very case of congenital scoliosis, and you can see that there are multiple the fusion anomalies in this thing, and this is how we keep we label each and individual jig, and we keep them on sterile on the table, and we use them to put the guide wires or the planning of our screws. So you can see that how the changes occur just from one level to the another, and we can pick up with these great changes in just at a single level with the help of these 3D printed jigs. And this is the post-operative X-rays. You can see a good sagittal as well as the coronal profile, and this is the clinical pictures. And this is the CT scan post-op. You can see that we could get with these 3D printed jigs. These are some of the examples which we could get these 3D printed jigs. So it is like putting navigation back into the surgeon's hand. The another topic is the advances which is coming up is in the field of the data. We know that our data is increasing day by day in volume and the complexity. We talk about anything in the medical field, it is increasing in complexity. And every 73 day, the medical data is expecting to being double. And we also know that by estimates that there is going to be a global shortage of healthcare workers by 2035. So we have we are going to face challenges with delivering efficient care. Already there are so many journals, so many articles, they are day by day and coming up. And if you look at the approximate amount of time which you read each work day to keep up with the new professional insights, you will need around 29 hours, which is not humanly possible. So here comes the role of the artificial intelligence. It is a term coined by John McCarthy. So basically, intelligence is then when computers can eventually learn, perform those tasks which a human can do without human involvement. Basically, you develop the algorithms that provide the machines the ability to solve problems that require human intelligence. So same like this, you go to the Netflix, and Netflix can suggest based upon your history and based upon your the choices of the movies which you have seen. They can suggest you the similar movies. Same if you go to a if you browse a certain product, then on your Facebook and on this thing, these products that came on coming up. Similarly on Amazon, if you buy a product, then it can suggest you the many things which the other people have bought, who have bought the same thing. So these are all sort of artificial intelligence. And actually if you look at this presentation also, this has been made with the help of the artificial intelligence tool from PowerPoint only. So basically there are several domains of the artificial intelligence which is changing our medical field day by day. One of this is the robotic spine surgery. The robotic spine surgery, currently we have many robots, but basically these three are the main spine robots: the Muzzafar, the Excelsius, and the Rosa spine. And they can also deal with depending upon the type, they can deal with the various preoperative modality. We have the Globus one, and it has the facility to navigate with both, with the intraoperative CT scan, preoperative CT scan, as well as with the fluoroscopy. And this is advanced because this has got cervical spine implications as well as the it is a fully integrated instrumentation is there, and it is a free platform. It doesn't require any fixation to the patient, so you can bring it whenever you need, and you can take it out whenever you don't need it. So this is very surgeon friendly. These are basically the parts of the robot. You have the dynamic reference array, and then you have the camera, you have the robotic arm, and then you have the monitor. So this is like the intraoperative picture. You can see that this is the dynamic reference base array, which basically it's a navigation guide, and this is the CT fixture by which you take the pictures intraoperatively. Like this is, we are using the intraoperative CT scan with the help of the O-arm. And once you have taken the O-arm, then you take out this intraoperative CT fixtures, and then you can see all the images on the screen, and then you can plan your trajectory and everything, and then rest of the work is done by the hand effector arm. You just press that which screw you want to put, and the robotic arm will come into that position, and you put your screws through them. So this is basically a real-time navigation of each and instrument implant is inserted. So basically it has got increased accuracy, safety with the reduced radiation exposure. It is very, very useful for the minimally invasive surgeries, and it ensures the navigation integrity. So at present, these spine robots, they are able to put to drill as well as to work as a screw guide. However, they are not able to do rod contouring, insertion, decompression, or fusion at present. Coming to the other aspects of the artificial intelligence, this is the machine learning and the deep learning. So the machine learning is when you use some sort of maths and statistics along and some algorithms in artificial intelligence. And the deep learning is that when you use some neural networks. So I will be dealing with the neural networks right now. So a very common question asked is, what is the difference between the machine learning and the statistics? So all things about the difference between the prediction versus probability. So if you see a hippie, you can say by his face that whether he's drunk or not. But suppose if I say what is the probability that all the hippies in that they will be the drunk, then it will be by the artificial intelligence just by looking at his face. So this is about the supervised learning and the unsupervised learning. This is again another thing. The supervised learning is like when you tell the machine that this is like you suppose we give the different pictures of the birds, and then you tell the computer that this is a duck, this is not a duck, then it's a supervised learning. But suppose if you just give him the different pictures of the birds, and then the machine can tell what is which looks like the same. So this is unsupervised learning. So the advantage of unsupervised learning is that if you like in a case of if I have the 1,000 patients of scoliosis, and we have the known classification. So if I feed the X-rays of 1,000 patients to the machine with unsupervised learning, so the machine can tell us that which X-rays, they fall in different clusters. This is like a black box phenomena. So so you put data into it, and then the data segregation comes out of the machine. So these machine algorithms, they can be run unsupervised, but they require frequent validations also. Now coming to deep learning, in deep learning we use the deep artificial neural networks. So these artificial neural networks, they are actually deep algorithms, and they have the separate science for that. This is a picture from the JBJS American, in which they have looked at the various aspects of the artificial intelligence going on in the field of the orthopedics, and this can range from the human decision making to the prototypic algorithms, like like there's an example, like you just feed the picture of the retina scan, and then can Google, it can diagnose the types of the diabetic retinopathy. The another advances is the natural language processing. So natural language processing is when the computer can read your medical records and your medical language. So like suppose if I this is an advancement, like if I want to post a patient of carpal tunnel syndrome release, I can just tell, I want to post this patient for carpal tunnel. So rest of the work and the paperwork will be done by the machine only, based upon your previous records which the computer has gone through, that what do you need as a preoperative workup, what do you need intraoperatively, and how do you go to proceeding. So this is again a natural language processing is coming up a big way. The another thing is called the Internet of Things. Now all of us wear, and as well as the have things like the iPad, the wearable watches, which are based upon the internet. So if we can incorporate these things into the healthcare, this is known as the Internet of Things, and what we call as the mobile health also. The one application of this mobile health is with the help of the sensors, which we can put in remote patient monitoring. Suppose you want to check the physiotherapy of a patient after UKR or a TKR, then you can put some sensors in it, and you can just monitor the physiotherapy of the patient. Or if I give a brace to a patient with scoliosis, I can monitor that how much time she or he is wearing that brace. So the major applications in spine comes in the image recognition, preoperative risk assessment, clinical decision making, analysis of massive data, and the predictive analysis as well as risk prediction. So there are several papers which are coming up in this field, where they can predict the mortality and morbidity after these surgeries. Uh, One another advance is the EOS imaging. It's a Nobel Prize winning technologies which reduces the radiation. We are fortunate enough to have this machine at AIMS, because and it can help you in getting the full screen, the full length X-rays with just 45 times less radiation as compared to a normal X-ray, and you can get a 3D reconstruction with the help of this thing. And so in case of scoliosis and the spinal pelvic deformity, it has revolutionized. So this is a Da Vinci picture where actually you can see from the each and individual vertebra from the topmost view, and then you can look at the various 3D subtypes of these classifications. Like this is an example of a Lenke 1 scoliosis, and when we looked at the X-rays, we thought that we have to just fuse the we can stop at L1 and we can go up to T4 to L1. This is the standard, this thing. But when we got the 3D analysis done, actually we looked at that the L1 is the most rotated vertebra. You can see, and obviously then we have to include this into our fusion, and we have to go beyond it. So this actually completely changed our plan. So this is the advantage of the EOS. You can see the pre-operative and post-operative X-rays. So we have also done a collaboration with the UK University collaboration, where we are using this artificial intelligence and the machine learning to predict the manufacture and the model of an orthopedic implant just by looking at this X-rays. The another common application is the FHIR, which is spelled as the FHIR, which is the Fast Healthcare Interoperative Resource. So this is coming up a big way, where all the patient data is integrated with the AI. We also working upon the several apps. So this is like we published this the SRS-22 questionnaire Hindi version. We validated it, and then we have come up with this app, which is available on Apple as well as on the Android platform. This is the A6 app, which is the AIM Spine Initiative, Crooked to Straight. So you can actually all the patients, they can fill up their SRS-22 questionnaire on their own at a regular follow-up, and they get the intimation that when their assessment is due. We are also working upon the application of artificial intelligence in the care of patients with scoliosis. We have collaborated with IIT. We have got the funding from ICMR. We have just started this work. The another area which we are working is the application of machine learning in predicting the surgical complications. So we have basically these artificial neural network structures with and we have all the data which we take it as the input layer, and then we use 80% of the patients training set, 20% of the patients as testing set, which is the standard methodology for the artificial intelligence, and then we look at the various outcome measures. So there are challenges also because it is a complex process. There are some ethical issues. It can lead to de-skilling of the surgeons as well. But these are all just hypothetical. This thing ultimately it is increasing our efficiency, and we must merge our health and the health data. The more important is that we have to give it as a human touch as well, which is the real AI or the augmented intelligence. Another areas which are coming up big way is the awake spinal fusions. We are also working in that. We have also our recent, very soon, JB just is going to publish a review article on the awake spinal fusions. So this is again a thing. We are also looking at the 3D gait analysis in these patients of the spinopelvic deformities and the scoliosis, and we have looked at these aspects also. We have also collaborated, for the developing these indigenous implants. These are, recent advances. We are working on the transcranial magnetic stimulations for bioprinting as well in spinal cord injury patients. So, everyone here has the sense that right now, we are going to influence our future, and we know that the best way to predict our future is to create it. Thank you.
Well, fantastic. That was really enlightening, of course, with the recent advances. Thank you, Dr. Garg. And can I now invite our next speaker? It is really Hatke, which was the theme this time. Dr. Harpal, finances for doctors. This is really obviously important topic, especially for those people who got a lot of money, or those people, even those who don't have money. So how to create more. Thank you. Over to you.
Good evening, everyone. At the outset, let me thank the Jammu Trauma Society, my friends in Jammu and Kashmir, for having invited me for this forum. Although this is Hatke, but this is my passion. And I would love delivering this talk. And the time Dr. Ghani told me कि हटके हो जाए इस बारी finance पे आ जाओ, तो I immediately said yes, because this is something about which I am very passionate. I won't formally introduce, but except for orthopedic circles, I'm more often known as either pelvis repairman or the ortho-vestor, because I'm an orthopedic surgeon and an investor. I have been in the stock market and in the finance from the time I remember. Even before I left school, I had gone into the stock market. I was a kid at that time, but still had the courage, or you can say the novice. Fools have a lot of courage. So I generally give my introduction. I'm an orthopedic surgeon by passion, but finance is my profession. The simple reason, I don't work for money. I don't do orthopedics for money. I do it for my passion. And even if I have to do it free, I would do it. So just hear this little video of Kapil Dev.
Of enterprise जो है life में, I really admire it, क्योंकि you're a serial entrepreneur. आप जब से retire करे, तब से you have a head for business. ये कहाँ से आया? Where do you think it's come from? जब मैं टेस्ट क्रिकेट खेल रहा था, तो हमारे मैनेजर थे चंदू बोर्डे. He was a former Indian captain. वो था. And हम बॉम्बे में टेस्ट मैच जीते, तो चंदू भाई आके बोले, मैं जा रहा हूँ पुणे, and I'll see you the next test match. तो 3 घंटे के बाद देखा चंदू भाई अभी वहीं है. बोर्डे साहब, मैंने कहा बोर्डे साहब आप गए नहीं, आप तो पुणे जा रहे थे. कहते नहीं, वो ना सेक्रेटरी बोर्ड का वो सो रहा है, वो उठेगा तो मेरा डेली अलाउंस देगा. उस एक स्टेटमेंट ने मेरी जिंदगी चेंज कर दी. इसलिए कि यार ये हमसे भी बड़े क्रिकेटर थे अपने टाइम में. आज ये नौबत है कि he have to wait for his daily allowance to go back. And that is the time I start thinking, open your mind कि क्रिकेट ही सब कुछ नहीं है. क्रिकेट छोड़ने के बाद ऐसी कभी नौबत मेरे को आई तो बहुत बुरा होगा, क्योंकि जब आप खेल रहे हो तो योर थॉट प्रोसेस और लाइफस्टाइल इज हियर, बट अगर इससे नीचे आ जाएगी तो यू विल स्ट्रगल, यू विल बी बिटर एंड यू विल बी.
So now you got to decide, you want to be Chandu Borde or you want to be Kapil Dev. You want to wait for somebody for your daily allowance, or you should have your own integrity and self-respect to do this. So why finance for doctors is a special topic. Majority of the people are made to believe, majority of the doctors are made to believe that you have lack of knowledge of finance and you have lack of time. Mind you, is it okay if I mix up Hindi with English?
Yeah, of course.
Yeah. So, मैं सबको यही कहता हूं कि यार तुम लोग PMT क्लियर कर गए, नीट क्लियर कर गए, ग्रेज एनाटमी पढ़ दी, 3 चौरसिया के वॉल्यूम पढ़ दिए, गाइटन पढ़ दी, तो फाइनेंस क्या चीज है तुम्हारे लिए यार? हाउ कैन समबडी से कि तुम्हें आती नहीं फाइनेंस? Those of you run your own enterprise, फाइनेंस इज पार्ट ऑफ यू एवरी डे. आप अपने वर्कर्स को सैलरी देते हो, अपना बिजली का बिल भरते हो, हिसाब किताब लगाते हो, दैट इज फाइनेंस. You run your clinic, you see how much I have earned every week or every month, that is finance. So that is just a way. Ugly cheese, this is how the kids enter into a med school. This is how the talented to be doctors are. This is a anyone, but this is not even 50% of the performance as compared to medical graduates. और ये जो लड़का है कल को आपका फंड मैनेजर हो सकता है और ये लड़की आपकी रिलेशनशिप मैनेजर हो सकती है. साला डांस तो आपके बराबर कर नहीं पा रहे तो कल को आपको फाइनेंस सिखाएंगे आके. So you got to decide what you want to do. The pertinent question and the answer and the problem here is we people start earning very late, and majority of us, unless we are in a salaried job, we earn cash. That's the problem, and the cash goes straight into the pocket and out of the pocket. And the last, which is most important, is there are no records and no analysis. Those of you who are in practice, just tell me before today, how many of you analyzed कि यार 18 में इतने केस किए थे और 19 में इतने केस किए हैं. Let's talk of trauma कि फीमर नेलिंग यार मैंने 20 की थी 18 में, तो 19 में मैंने 30 की, लेकिन मेरी इनकम तो 1.5 गुना नहीं हुई. Does anybody do analysis? Any gynecologist do they analyze कि पिछले साल इतनी डिलीवरीज थी, इतने साल इतनी है? उनको पता होगा क्योंकि उनको बर्थ रजिस्टर करवाने पड़ते हैं. बट डू दे एक्चुअली लुक एट कि मेरी रेवेन्यू जनरेशन भी बढ़ी है कि नहीं बढ़ी है? डॉक्टर घनी कैन से यार मैं 18 में तो सिर्फ 5 THR किए थे, इस साल 25 किए हैं, बट हैज हिज इनकम बिकम 5 टाइम्स? अगर नहीं हुई तो क्यों 5 गुना काम कर रहे हो भाई?
इसलिए तो टॉपिक दिया है.
राइट. सो अगली बात है, इनसिक्योरिटी बहुत है हम लोगों में. डॉक्टर्स के साथ क्यों इतना धक्का होता है हर जगह पे? यह वीडियो देखिए, आज की है. This gentleman is the nodal COVID officer in one of the main states of India. And the two gentlemen here, one is a Gunda, local Gunda, and the second is a MLA who was an ex-minister in the last government, and they are shouting at him. अब क्या नतीजा होता है? Doctors, क्यों everybody takes us for a ride? Many of us might have faced this circumstance. Has any one of us ever taken action against it? मैं एग्जांपल देता हूं. एक बारी राजीव गांधी को प्रेस कॉन्फ्रेंस में पूछा गया था कि आपके फॉरेन सेक्रेटरी में ऐसा स्टेटमेंट दिया है, एंड ही गेव अ आंसर दैट यू विल सून सी अ न्यू फॉरेन सेक्रेटरी, एंड हिज फॉरेन सेक्रेटरी रिजाइंड आफ्टर द मीटिंग. बाहर निकल के उसने रिजाइन कर दिया. अब मैडम सीतारमन ने भी किसी एक अपने उसको बदला था, फाइनेंस सेक्रेटरी को, ही रिजाइंड. कितने डॉक्टर आपने सुने जो रिजाइन कर देते हैं जब ऐसी बात होती है? Because we are so insecure. एक IAS at the fag end of the career, when he's a national central government secretary, he resigns at the top of his career कि नहीं मैं काम नहीं करूंगा, अगर ऐसे बोलोगे तो मैं काम नहीं करूंगा. But how many doctors do they resign? Reason is insecurity. But this gentleman resigned immediately after this incident and sent his letter to the chief minister that in this situation, after having worked for 1 year day and night, I cannot work. Even if this person is given punishment, I am not in a frame of mind to come and work because आज ये मेरे को गाली निकाली है, कल मेरे को नाइफ मार देंगे या मारपीट करेंगे. He is given a unconditional resignation with salary कि मैं नहीं आऊंगा कल से काम पे. अगर आप इस तरह की सिक्योरिटी लेके रखोगे, इस तरह के स्टेप लोगे, पीपल विल स्टार्ट रिस्पेक्टिंग यू, बट वी कांट डू इट बिकॉज वी आर इनसिक्योर. अब ये तो होगी इंट्रोडक्शन. लेट्स गो टू द नाउ फाइनेंशियल पार्ट ऑफ इट. ह्यूमन माइंड जो होता है, जैसे डॉक्टर भावुक कह रहे थे, इज मशीन लर्निंग एंड आर्टिफिशियल इंटेलिजेंस आ रही है. ह्यूमन ब्रेन इज ट्रेन्ड फॉर अरिथमेटिक. 2 into 2 4, 2 into 3 6, 5 into 5 25. लेकिन रिमेंबर, यू ट्राई टू रिमेंबर व्हेन वी वेंट इनटू 9th और 10th, तो लॉग फंक्शन आता था, लॉग टेबल साथ लेके जाने पड़ते थे, एंड मेजॉरिटी ऑफ द क्लास वाज एट अ लॉस बिकॉज ह्यूमन ब्रेन कैन नॉट परसीव कंपाउंडिंग एंड लॉग फंक्शन. सिंपल सा सवाल है, पूछो 50% रिटर्न इन 5 years, तो एनुअल रिटर्न क्या बनी? मेजॉरिटी ऑफ द पीपल वुड से 10%. दैट्स नॉट एक्चुअली राइट, दैट्स रॉन्ग. It's actually 8.45% annual return, which will make it 50% return in 5 years. So 1% does not make 12% annual. 12% annual return will be 0.95 monthly. 1% monthly return will result in 12.68% annual. इसी हेर फेर में हमारे साथ, जब हम कार का लोन लेते हैं, होम लोन लेते हैं, इसी की हेर फेर करते हैं हमारे साथ बैंक वाले. That is why we must know this. कि उसकी कंपाउंडिंग किस लेवल पे होनी है, वो हमें घुमा फिरा के करके पेपर साइन करवा लेते हैं, देन वी रियलाइज कि मेरी तो किस्त ज्यादा बन गई, इतनी बननी नहीं चाहिए थी. All must have experience, They will give you a loan कि सर मैं सस्ता कर देता हूँ, 3 किस्तें एडवांस में दे दीजिए. आपकी प्रिंसिपल अमाउंट ही कम हो गई, आपका रेट ऑफ इंटरेस्ट तो बहुत ज्यादा हो गया. So we all know about it. बहुत पॉपुलराइज किया गया कि सिप करो, बड़ी एड भी आती है, म्यूचुअल फंड सही है, टीवी पे आता है. That is just like investing equal amount every month or every quarter depending on your own budget and your habits. जिस तरह किसी को आसान मिलता है, right? And we have different instruments, different kind of mutual funds where we can invest. तो इसमें कंपाउंडिंग जो होती है उसको हम IRR कहते हैं, इंटरनल रेट ऑफ रिटर्न होता है, जिसको हम आगे चलते हैं. अब थोड़ी सी बात इंश्योरेंस की करें. ज्यादातर हमें जो भी इंश्योरेंस बेचने वाला होता है वो हमारा या रिश्तेदार होता है, या क्लोज फ्रेंड होता है, या क्लोज फ्रेंड का रिश्तेदार होता है, या रिश्तेदार का क्लोज फ्रेंड होता है. ये 4 से 5वां बंदा नहीं आपको मिलेगा कोई बेचने वाला. और वो सारे आपको या तो यूलिप बेचेंगे और या चाइल्ड प्लान बेचेंगे. यू टेल मी, चाइल्ड की इंश्योरेंस का क्या काम है? लॉस ऑफ अ चाइल्ड इज नॉट financial loss, it's an emotional loss. और यूलिप और चाइल्ड सबसे बड़े प्लान्स और सबसे बड़े स्कैम्स, एंड दे आर लेबल्ड एज इग्नोरेंस पॉलिसीज. इसमें एक ही बंदे का फायदा होता है वो है आपका एजेंट जिसने आपको ये इंश्योरेंस बेची है. The only insurance that you should get done for yourself is term insurance. मैं मेडिक्लेम की बात नहीं कर रहा हूं. मेडिक्लेम इज सेपरेट. दिस इज लाइफ इंश्योरेंस. इसमें सिर्फ टर्म इंश्योरेंस करानी है. लोग फिर मेरे को बोलते हैं जी उसमें पैसे तो वापस नहीं मिलते. मैं पूछता हूं यार गाड़ी की इंश्योरेंस कराते हो पैसे वापस मिलते हैं? कभी कोई इंश्योरेंस वाला कहता है जी होंडा की इंश्योरेंस कराओ तो 10 साल बाद मारुति साथ में दे देंगे जब ये खत्म हो जाएगी. तो अगर गाड़ी की इंश्योरेंस टर्म इंश्योरेंस करवाते हो तो अपनी क्यों नहीं टर्म करवानी? दिस इज यूलिप इज सो एक्सपेंसिव. एंड मैं आगे दिखाता हूं कितनी उनको कैसे आपको इतना कन्विंस करते हैं. एंड आई कैन अश्योर यू मेरे कहने के बाद भी आप जाके उनसे इंश्योरेंस की यूलिप फिर करवा लोगे बिकॉज दे विल बी एबल टू कन्विंस यू. वो कन्विंस क्यों करेंगे? मैं ये लेक्चर फ्री में दे रहा हूं. उसको पहले साल एक इंश्योरेंस बेच के 35,000 रुपया मिलना है. तो जितना वो आप पे टाइम लगाएगा मैं उतना नहीं लगा सकता. फर्स्ट ईयर कमीशन इज 35,000. आपने अपनी तरफ से 1 लाख रुपए इन्वेस्ट किया. आपकी इन्वेस्टमेंट तो 50,000 भी नहीं हुई. 35,000 उसकी कमीशन चलेगी. 15,000 आपकी टर्म इंश्योरेंस का प्रीमियम चलेगा. पीछे रह गया 50,000. वो इन्वेस्ट हुआ आपके लिए. 1,10,000 रुपया तो 15 साल में वो ले गया. आपको क्या मिलना है? So please, ULIP, child plan or investment plans, insurance is not for investment. आप ट्रक लेके हॉस्पिटल नहीं जाते हो, आप गाड़ी में जाते हो. These are ignorance policies. Please don't invest. If you have invested, stop giving more premiums and take your money out as quickly as possible. Because जितने साल रखोगे उतने साल आपका नुकसान हो रहा है. जितने प्रीमियम दोगे उतना और नुकसान होगा. वो आपको फिर समझाएंगे सर बंद ना करो 10 साल चलने दो क्योंकि उसको 10 साल कमीशन मिलता रहेगा. फिर हम म्यूचुअल फंड्स की बात करते हैं. व्हेन वी इन्वेस्ट इन म्यूचुअल फंड्स, जिसकी हमने सिप की बात करी थी, शुड ऑलवेज बी डायरेक्ट प्लान्स एंड ग्रोथ. वो आपको कहेंगे सर रेगुलर में मैं आपको रिटर्न ही ज्यादा दे रहा हूं. दैट्स टोटली फॉल्स. दे आर नॉट गिविंग यू एक्स्ट्रा रिटर्न्स. दिस इज नॉट माय डेटा. दिस इज डेटा फ्रॉम द म्यूचुअल फंड MFI. Look at the annualized return, but look at the expense ratio. इसकी 2% है, इसकी 1% है. It is not difference of 1%. It is double. 25,000 आपने इन्वेस्ट किया for 30 years. It became 5.17 crores at 12% return. Arbitrarily ले रहे हैं. इधर भी 12% मिली. इधर 6.46 करोड़ बना. And what is the difference? 1.29 crores. Boss, he's driving a BMW on your money. This is the graphical representation. If you put 10,000 per month for 30 years, a difference of expense ratio of 1% would make it how much? So जो ये 50 लाख देना चाहते हैं, I am happy to receive it. I will do the dirty work for you for 30 years. 30 साल बाद मेरे को 50 लाख इतने लोगों के इकट्ठे हो जाएंगे. That will make my life. I don't need to work. So that is why they sit in their AC offices and do nothing. फॉर्म भरने के लिए भी बंदे रखे होते हैं उन्होंने. And I am not getting the information out of nowhere. These are few commonly used famous funds. Look at their expense ratio. डायरेक्ट में 0.52, रेगुलर में 2.21. में डबल भी नहीं है, इसमें 1% का भी डिफरेंस नहीं है. 1.7% डिफरेंस है. यहाँ 0.41 या 1.88, 1.47 का डिफरेंस है. These are just few and you will find it in every fund. So please, अगर आपके कमीशन एजेंट के साथ हैं तो tell him that I will pay you upfront 100,000, 500 जो लेना लो, लेकिन मेरे को डायरेक्ट फंड में अप्लाई करना है. अपनी पुरानी सिप बंद करो. Don't take your money out. Leave them for 1 year so that you enjoy the taxation and the expense ratio. Start your new SIP in the direct funds. After 1 year, shift your fund from the regular to the direct fund. Now, this is a real-time example of SBI blue chip fund. $10,000 in direct, 10,000 in regular for 5 years. This is the return. This is as per actual at the SBI mutual fund website. A difference of 1.13 lakhs in 25 lakhs. Percentage आप खुद कैलकुलेट कर लो कितना डिफरेंस हो गया. So your approach to your finance should be goal based. पहले तो बात हो गई इग्नोरेंस पॉलिसीज नहीं लेनी. हमने म्यूचुअल फंड में इन्वेस्ट करना है, इक्विटी में करना है, वो जरूरी है क्योंकि वी वांट टू बीट द इन्फ्लेशन. वी नीड टू नो द कंपाउंडिंग. पर पैसा कैसे इन्वेस्ट करना है, इट शुड बी गोल बेस्ड और योर गोल शुड बी स्मार्ट. Now, what do I mean by smart? It has to be specific. It has to be measurable. It has to be achievable, reasonable, and time bound. ये क्या है? Let's take an example. So, like I am at that stage, let me tell you, goal is marriage of your child. So, time value of the money आपको पता होनी चाहिए. आज की डेट में अगर आप कहीं अच्छे होटल में शादी करने जाओगे, the plate costs about 2,500. And if you invite 500 guests, you know कि 12.5 लाख के करीब खर्चा आएगा आपका. Now it is 10 years away and inflation is about 7%. तो 10 साल बाद अगर मैंने ऐसी शादी करनी है तो मेरे को कितने पैसे चाहिए होंगे? So इसमें एक बहुत सिंपल फॉर्मूला है which we call as formula of 72. अगर आपको रेट ऑफ इंटरेस्ट पता है तो आप 72 को उस रेट से डिवाइड कर दीजिए. राइट? और अगर आपको ईयर्स पता है तो वो आपको रेट ऑफ इंटरेस्ट बता देगा. सो अगर मैं 72 को 7 से डिवाइड करता हूं तो रफली मेरे को 10 मिल गया. इसका मतलब है कि 10 साल में ये रेट डबल हो जाएगा मिनिमम. अगर इन्फ्लेशन बढ़ गई ज्यादा भी हो सकता है. So this at 7%, this rate will become double. So ये प्लेट 5,000 की हो जाएगी 10 साल में. This is minimum. So मेरे को कम से कम 25 लाख चाहिए होगा तब. ये तो श्योर है, इससे ज्यादा की जरूरत पड़ सकती है, इससे कम नहीं होगा. So I have a goal which is specific, marriage, which is measurable, which is achievable, which is reasonable, and is time bound. ठीक है. इसी तरह एक और मैं आपके लिए एक्सरसाइज छोड़ देता हूं कि आज 2021 में इस साल MBBS fee for the first year in unaided private colleges is 10 lakhs. If your child is going into a medical college in 2024, how much fee will you pay? The government has approved 10% increase every year. So this exercise you can do at home. So, पर स्टॉक मार्केट से सारे डरते क्यों हैं? जब भी कोई बात होती है स्टॉक मार्केट की, पीपल थिंक इट इज अ सट्टा, जुआ है ये तो. द रीजन इज पीपल वांट टू हैव आर यूज्ड टू द एफडी की 1 लाख रुपया दिया, साल बाद 1,04,000 रुपया या 1,05,000 मिल गया. स्टॉक मार्केट डजंट बिहेव इन दैट वे. हो सकता है फॉर 4 years you may not have even a return or maybe negative return, and the 4th year might give you excellent returns. Let's take an example of Reliance. It was a sleeping giant for 8 years. And then in 1 year, it's grown more than double. So whenever you talk of equity, you always talk in periods of 4 or 5 years, never less than 4 or 5 years. So जो भी चीज की आपको प्राइस किसी स्टॉक की देखनी है, आप 4 साल पहले से उसको कंपेयर करो, ओवर 4 years उसकी क्या इंक्रीज हुई है, एंड चेक द कंपाउंडिंग कि 4 साल में सिंपल नहीं देखना, उसको कंपाउंडिंग रेट में कितना उसने एनुअल CAGR कितना दिया, दैट इज व्हाट वी वांट टू नो. अब निफ्टी की रिटर्न ले लीजिए, कोई कहता बड़ी चॉपी है. आई एग्री इट इज चॉपी. लुक, इट वेंट हियर, इट वेंट हियर, इट वेंट हियर, इट वेंट हियर, फिर ऊपर जाके फिर नीचे आई. बट लुक एट दिस लाइन, इट्स बीन राइजिंग वेरी स्मूथली. हमें एज ए इन्वेस्टर ये राइज चाहिए, हमें इनसे कुछ नहीं लेना देना, हम तो सिप कर रहे हैं. ये फिर फॉल आया, कितना जबरदस्त फॉल आया, लोगों ने पहले ही कह दिया अब तो मार्केट खत्म हो गई, रिसेशन, दिस एंड दैट. एंड लुक एट द वे, मैं तो अभी आई हैव नॉट इंक्लूडेड द फर्दर चार्ट, लुक एट द रिकवरी. And now it's made all-time high and is still going high. People are still saying there'll be lockdown. As an investor, we are not concerned where the market goes. We have to keep on doing SIP. So risk क्या है stock market में? Is randomness of return. हमारी expectation है 12% की कि FD plus inflation मिल जाए हमें. आजकल FD 5% हो गई है, inflation is 7%, so 12% आ जाए. जिस साल तो अचीव हो गया तो वी आर वेरी हैप्पी, नहीं होता तो वी कहते हैं स्टॉक मार्केट सट्टा है. दैट्स नॉट एक्चुअली ट्रू. वेरिएंस इन रिटर्न इज रिस्क, बट वी शुड गो बाय स्टैंडर्ड डेविएशन एंड CAGR. So hidden expenses are also a risk, which we should be very careful about. So SIP should be fixed amount, investment over a period of time. Time is the diversification. It will take care of the risk. Average cost will come down, the risk will reduce. Don't exit till your final goal is achieved. It is very easy and it increases your rate of return. It's something as simple as closed femur nailing, but you still can have complications. That's okay. So what is SIP? Is buy low, but buy less when high and buy more when low. अपने आप हो जाता है. So to decrease your risk, it is diversification, and diversification can be in many types. Diversification of assets, gold, real estate, equity, and debt. Doctors generally concentrate on real estate, but real estate is not easily liquidable. अगर किसी दिन पैसे की जरूरत पड़ती है, आप बेच नहीं पाओगे. And it's been in bad times for a very long time. Gold has given very good returns. According to age, debt should be maintained. So diversification can be in company size. मतलब आप large cap mutual fund में लगाओ, आप mid cap में लगाओ, small cap में लगाओ, right? But diversification is must. And the other two durations are, diversifications are long duration. अगर आप 30 साल के लिए पैसे लगा रहे हो, market 30 साल में तो बहुत आगे जानी है. And dip buying. जब मार्केट आपको लगे नीचे है, rather than running away from the market, buy more. Amazon पे सेल लगती है तो क्या करते हो? जो चीज एक चाहिए वो दो ले लेते हो, जो चीज नहीं चाहिए वो ऑर्डर कर देते हो. So if you're doing SIP and market crashes, double your SIP. So what should be your portfolio? It has to be low cost. ये ideal है. Diversified. Risk should be under control and you should have a benchmark. तो benchmark इंडिया में Nifty is a very good benchmark. Top 50 companies of the country. Companies बदलती रहती है, Nifty वही है. Some companies will be part of Nifty 50 for a few years, then they might move out. Doesn't matter. हमारे पास तो top 50 हैं. So हमारी diversification भी हो गई, हमारा risk भी हो गया, क्योंकि Nifty cannot become zero. India zero नहीं हो सकता. कोरोना नहीं zero कर पाई, कोई नहीं कर पाएगा. So we should look for Nifty index fund. Index मतलब जो Nifty में पैसे लगाते हैं. अगर हम Nifty खरीद रहे हैं तो वो कभी जीरो नहीं हो सकती. We are clear on that. And once it cannot go zero, then it is the safest option to invest in that. अब Nifty का इंडेक्स फंड हमें वो चाहिए जो लो कॉस्ट हो और जो बेंचमार्क को फॉलो करता हो. So that is what we have to look for. And हमने हमेशा Nifty 50 में, जिसने ज्यादा करना है वो Nifty नेक्स्ट 50 में लगा सकता है. हमें चाहिए डायरेक्ट और ग्रोथ. कभी रेगुलर फंड में पैसे नहीं लगाने, हमेशा डायरेक्ट में लगाने हैं, और कभी डिविडेंड ऑप्शन नहीं लेनी, हमेशा ग्रोथ ऑप्शन लेनी है. बिकॉज प्रेजेंटली विद द रूल्स एट दिस पॉइंट ऑफ टाइम, डिविडेंड इज टैक्स्ड एट 30% एंड लॉन्ग टर्म कैपिटल गेन इज टैक्स्ड एट 10%. सो सीधा 20% का फर्क है. तो हमने डिविडेंड ऑप्शन में कभी पैसे नहीं लगाने, हमेशा ग्रोथ में लगाने हैं, और कभी कमीशन नहीं देनी, सो हमेशा डायरेक्ट पे लगाने हैं. सो टेक होम मैसेजेस. You should have a goal-based approach, understand compounding. Your portfolio should be low-cost index fund, direct and growth, only term insurance, no ignorance policies, invest in knowledge, find a good mentor, and control the urge for purchases of pleasure. जो आपने 10 साल पहले इन्वेस्ट कर दिया, अगर आप आज करोगे, बहुत ज्यादा पैसे चाहिए होंगे, you won't be able to match it. So first invest from the saving, जो बच जाए, पहले खर्चे, घर के जरूरी खर्चे, फिर उसके बाद इन्वेस्टमेंट. Whatever is left, that is the money that you should spend, right? Understand the need to learn finance, read books. This is just a list which I really love. Rich Dad, Poor Dad, The Little Book of Common Sense Investing, Value Averaging, the Safe and Easy Strategy for Higher Investment Returns, and of course, Zero Diversity. I must acknowledge in my lecture, my brother-in-law, Mohanbir Singh, Varun Malhotra, my friends Amit Sapra, Vijay Arora, and Rupan Kaushal, from whom I've gained a lot of knowledge of finance, and they taught me a lot of things which I didn't know before. And Ramnath Gutte and Prashant Pachore have been two mentors to whom I owe my lot of my success in finance. WealthCon is an initiative by Dr. Ram where only allopathic doctors with MBBS and higher degrees are allowed. This is something I would suggest that you should join to learn more about finance. Thank you.
Thank you, Dr. Harpal. Wonderful. That was obviously not orthopedics, but something really important. Thank you. I think there will be some question towards the end of the session. Now I request my friend and my colleague from GMC Jammu, Dr. Manish Singh, to present his talk on cartilage repair options in young non-arthritic knee. Thank you. Over to Dr. Manish.
Dr. Harpal, very nice presentation. And you are my offline mentor now. I'll be disturbing you on and off. So I'll be talking about cartilage treatment options in young non-arthritic knee. We know articular cartilage is a complex structure composing of different layers from superficial zone to the calcified zone, and it has a very precarious blood supply. That's why the healing potential is very less. ICRS has classified it into 4 types. Grade 1 and 2 has lesion which extended less than 50% of the cartilage depth, and grade 3 and 4 in which the cartilage damage is more than 50%. And this is the subset of group which requires some sort of intervention. Symptoms associated with cartilage damage are uncomfortable feeling, pain, on and off swelling, stiffness, mechanical symptoms, pseudo instability, and inability to perform in certain positions. There are various causes like trauma, osteochondral defect, osteochondral necrosis. And there are some location-specific features of cartilage damage. Medial femoral condyle is the most common involved, and lesions are usually posterior medial. It is usually associated with meniscal and chronic ACL tears. Lateral femoral condyle, in this, the lesions are anterior located, and it is commonly associated with patellar dislocation or acute ACL injuries. Tibioplateau is less common. Lesions are posterior lateral and is commonly associated with ACL injuries. Patella being the second most common, and the lesion is on the inferior medial facet. They are associated with anterior knee pain, which is early inflection, and they are commonly associated with patellar dislocation and dysplasia. The trochlear lesions are difficult to diagnose clinically. There is a knee flexion pain. Usually they are caused by ACL reconstructions. So the current practices and available treatment options include microfractures, ACI or autologous chondral implantation, mosaicplasty or OATS, and osteochondral allografts. In microfracture, we debride the cartilage damaged area and we will take out the subchondral ossified layer, sclerosed layer, and then we drill holes at 3 to 4 mm bridge and let a clot form, which ultimately gets converted into fibrocartilage tissue. The advantage is a single stage, cost effective, and faster rehabilitation protocol. But it has a to a long time result. Now the ACI is, in this case, we take a biopsy from a healthy cartilage, amplify our culture at outside, then this cultured chondrocyte is injected into the damaged cartilage. Advantages, it showed good results and can be used in more sized lesions. Disadvantages, it is two-stage because first time you are supposed to take the cartilage and then culture it outside. There is a donor side morbidity can be associated, but it is very expensive and rehabilitation is very slow. The mosaicplasty is where we take the plug of the cartilage and bone from the non-articular area and these are incorporated into the defect area. It is a single stage surgery and mature hyaline cartilage is used and it is a faster rehabilitation method. The disadvantage is now possibly we have created two surgical sites and there is associated donor side morbidity. Osteochondral allograft, they are taken from the cadavers. There is no donor side morbidity. Mature hyaline cartilage available. It's useful in large lesions. It is expensive, requires extensive preparation, and they are potentially immunogenic, and they usually are not available even in India. So while repairing a cartilage, the major consideration is lesion, the size of the lesion, the depth and containment, whether the surrounding cartilage is healthy or not. And joint has other deformities such as meniscal injuries or alignment issues or stability, and definitely age of the patient and BMI, because the obese patient do not tolerate these sort of surgeries. So lesion size is a very important aspect, and we have classified into small, mid, and large lesion. Small lesion means when it is less than 1 to 2 centimeters square. Medium lesion is when it is 2 to 4 centimeters square, and large lesion is when it is more than 4 centimeters square. In case of small lesion, microfracture shows a good clinical outcome and has a low postoperative demand. Oats can be used, but it is supported by literature also. ACI and allograft are too costly and too demanding for small lesions. Whereas in medium lesions, if treated by microfracture, it deteriorates over time if the lesion size is more than 3.6 centimeters square. But there are studies which have showed that microfracture and oats are similar in low activity patients. But in case of athletes and high demand patients, the microfracture deteriorates very rapidly. And ACI produces enhanced long-standing clinical and functional result in mid-sized lesion. So deciding in a medium-sized lesion, microfracture has a high failure rate and in low demand patient, it can benefit. Oats is a single stage, cost-effective arthroscopic procedure, ideal for mid-sized lesion. ACI, as the size gets bigger, favor ACI over oats because there is no congruency issue and it has good long-term result and gives a hyaline right repair. Now coming to large-sized lesions, it has been shown that oats, there is a donor side morbidity which has been up to 6% as documented by Andre. There is contouring issue because the whole of the cartilage, it is not a flat surface, it's a rounded surface, and we cannot have the flat surface from those limited donor areas, and it becomes technically demanding if we are taking too much plugs. ACI has showed a good survival rate of 86% in adolescent after 10 years and overall survival rate of 63% after 20 years in general public. So in large lesions, microfracture and oats should be avoided. ACI, if justification of the cost and two-stage procedure can be done, no size restriction as compared to oats. Add bone graft of subchondral if subchondral involvement is there. It has superior results compared to microfracture and oats. Though allograft are also a single stage, and in cases of subchondral involvement, they can also be done. They have a long survival, no size restriction is there, and because they are taken from a cadaver, there is no donor side morbidity, but they are not easily available. So this is a surgical algorithm which shows that if the lesion is less than 2 centimeters and if it is chondral, then do a microfracture, and if it is osteochondral, go for single plug oats. When a lesion is 2 to 6 centimeters, meaning mid to large, Then if it is a chondral, then go for ACI. And if it is osteochondral, go for OATS or mosaicplasty. Mosaicplasty means when you're using 2 or more than 2 plugs. If the lesion is very large, and if it is chondral, do an ACI. And if it is osteochondral, do an ACI or allograft, whichever is available. Take home message is consider all variables before finalizing the treatment method. Age, activity level, etiology, location, size, depth, and other comorbidities should be assessed. Size of the lesion is the single most important factor. And in small lesion, microfracture is good. If high demand, then do an OATS. Medium lesions, we can do OATS or ACI. If low demand, we can still do microfracture, but be cautious. Large lesions, go for ACI with or without bones grafting or allograft, depending on surgeon's experience and logistic. But we should not ignore this cartilage lesion, so they further progress, and then they will require a knee replacement after a couple of years. Thank you.
Thank you, Dr. Manish. Wonderful presentation. I think next speaker, Dr. Aarti. I don't think she's around. So we invite questions for this session before we close the session. Any comments, any question from any speaker or panelist?
I have a question for Dr. Harpal, sir.
There will be a lot of questions to Dr. Harpal only, my sir,
I have invested in Franklin Direct Funds. And how should I decide the amount every month?
See, that is you have to decide. I gave you a rough guideline, like the marriage. So you got to decide, you got to have different goal-based portfolios. Like you can have for the higher education of your children, if you have 2 kids, you can decide one is 7 years down the line, the other is 9 years down the line. Then, if they get into medicine or if they get into engineering, then they will like to do MBA. If PG or MBA, then you decide on the higher education. The next portfolio would be, just let me finish. The next portfolio would be their marriages. And finally, the last and the most important portfolio is your retirement.
Sir, let me simplify.
That is how I go about it.
If I'm earning 100 rupees a month, how much should I invest?
See, if you're earning 100 after taxation, it's not how much you need to invest. First, decide on these 7 portfolios.
Okay.
And if you need to invest 60 rupees, then you make sure that you run your house in 40 rupees.
Okay, sir.
To make your life easier. Because जो आज 60 में पूरा हो रहा है, वो कल 70 में होगा. And income may not go to 110. Like I'll give you an anecdote. Last January, I was telling everyone, including my children, we are going to see some very tough times. So please control your expenses. जो फालतू के खर्चे सब बंद कर दो. And people used to laugh at me. And when the lockdown happened, leave aside people who are in government service and were getting their salary every month. Those, like in Jammu, you guys are practicing. We are in Ludhiana, we are practicing. We are allowed private practice. The people who were in private sector, the hospitals did not have any orthopedic work. So you ask them how difficult it was to run the home. Your expenses continued. If you run a clinic, you can't tell your clinic attendant कि मैं तेरे को salary नहीं दूंगा. Who's been working with you for 10 years, 20 years. So still the pandemic is not over. My very important take home message is these are very difficult times. We do not know when and how we will come out of it. So please, there's one thing for sure that you can control, that is expenses.
Great, thank you.
My comment to moderator, Dr. Ghani sir.
Yeah, please.
हरपाल सर का लेक्चर सुनने के बाद अभी मेरे को अपना लेक्चर देने का थोड़ा परेशानी आ रही है, तो पार्डन मी फॉर माय प्रेजेंटेशन कि कैसे बोलूंगा. It was an eye-opening lecture, especially for the youngsters, because we take things lightly and then definitely. Thank you, Harpal sir, for a wonderful lecture.
I agree with you, Rashid. My question: what about Bitcoin?
See, Dr. Ghani, मैं एक चीज इसमें बहुत I am not invested. That is first disclosure. Second, हम कोई भी चीज लेते हैं, जैसे आप मान लीजिए अगर आप जम्मू में प्रॉपर्टी देखते हैं कोई, तो आपको ये होता है यार ये 1 करोड़ की है, क्यों है? क्योंकि अगर यहाँ पे शोरूम होगा तो उसका रेंट 1 लाख आएगा। तो आप थोड़ी हटके देखते हो तो कहते हैं यार ये 50 लाख की है, क्यों? यहाँ भी कोई इंटरेस्टेड नहीं है। दिल्ली कनॉट प्लेस में चल जाओगे, उसी साइज की प्रॉपर्टी शायद 20 करोड़ की हो जाएगी। Location and rental value and yield will be more. So similarly in the stock market, कि जो आप चीज लेने जाते हो उसका वो कहते हैं रिलायंस बहुत महंगा है जी आज, क्यों है? वन इज द इमोशनल कंपोनेंट, सेंटिमेंटल, एंड सेकंड इज कि रिलायंस ने पैसा बहुत कमा रहा है जी। अदानी के आप शेयर्स देख लो, आग लगी हुई है, क्यों? क्योंकि हर चीज ही अदानी की है। So no political angle to it. We are discussing very cleanly on the academic forum. So Bitcoin की earning क्या है? You know, it's just like gold की एक value है। You know, we know कि जब 1947 में partition हुई, one part of my family, my maternal side was from Pakistan. तो पैसे की जगह भी वो सोना उठा के भागे वहां से, क्योंकि उनको पता था सोना कहीं भी देके पैसे मिल जाएंगे। So that is why we always say gold standard. Even in pharmacology, we used to remember what is the gold standard treatment of this. आज भी यही बात होती है। Why don't people say diamond standard or silver standard of this? So Bitcoin की कोई, it is a virtual currency. But one thing I can tell you, once the government regulates it, it becomes a legal thing. Bitcoin is here to stay.
Okay.
पर आज जो valuations हो रही हैं उनका कोई रीजन नहीं है, कोई कुछ नहीं है। It is like सट्टा मार्केट है, आपने खेलनी है तो खेलो। But I will wait till it gets regulated. I might get it at $1 lakh a Bitcoin आज 60,000 की जगह. But I'll be more satisfied if it is regulated and it is legal thing. दूसरा रीजन ये है, आपके पास बिटकॉइन है, आपका चोरी हो गया, कोई और ले गया निकाल के, माइन करके ले गया आपसे, आपका हैक करके, there is nothing you can do about it.
Absolutely.
It is just like आपकी जेब से कैश गिर गया। So जो अनकाउंटेड कैश होता है ना, ये पुरानी कहावत है, कहते हैं या बीमारी ले जाती है, या चोर ले जाता है, या राजा ले जाता है। एंड वी ऑल हैव फेस्ड द थर्ड थिंग इन डिमोनेटाइजेशन। जिनके पास कैश पड़ा था, बहुत लोगों का कैश गया। ठीक है ना? सो इट इज दैट इज सेकंड, टैक्स चोरी नहीं करना, टैक्स को बचाना है इन लीगल मेथड्स।
Legal ways.
And there are a lot of legal methods. When you go into the advances of finance, there's a lot of things you can do to decrease your taxes. ये लोग जो हमारे CA हैं हमें बताते नहीं, these things are for HNI clients. High net worth individuals हैं जो वो ऐसे गेम खेलते हैं कि उनकी जितनी इनकम होती है वो 15% पे टैक्स होती है। They create losses at some place which take away the income, and they will create a profit where there is only 15% or 10% tax.
Right.
But this is only for business people, not for salaried people.
Okay. Next question. Again, slightly to Dr. Harpal only. In properties, real estate, which is better? Plot or flat or shop or commercial or whatever? Dr. Manish is laughing at me. Obviously, everything we are working hard day and night, practice. And if we don't know this dynamic, why do we have to take extra stress? So I think this is important.
So it depends on for what purpose are you buying it. If you are buying it as an investment, and depending on which city.
Yeah.
आप पंजाब में लोगे तो फ्लैट की कोई वैल्यू नहीं मिलेगी जिस दिन बेचने जाओगे. It's difficult to sell a flat.
Right.
In Delhi, you won't find a plot. And if you find a plot, it's very expensive. Again, it will be difficult to sell.
Absolutely.
So for investment, I would always go for a plot. And in bigger cities, flats are a good investment. Commercial property, if you want to look for rental yield, commercial properties are the places to go. But India में एक problem है, जैसे a person like me who does not have black money, or non-taxed money,
At
The
least
property is very difficult to buy because majority of the component in property purchase is do number ka. So that is one of the reasons I find it very difficult to invest in real estate.
Yeah.
But I would prefer to invest in commercial real estate rather than in buying a house to give it on rent. So आप Rich Dad Poor Dad पढ़ो, आपको बहुत सारे questions वहां से answer हो जाएंगे.
Great. I think that was really.
The house you live in is a liability. It's not an asset.
Absolutely.
So that is the first thing that one should learn. Doctors का क्या होता है, सबसे पहले घर खरीदते हैं, फिर उसको भी खराब करते हैं, उसके एक कमरे में क्लिनिक खोल लेते हैं. ना घर की प्राइवेसी होती है, ना क्लिनिक पूरी चलती है.
Absolutely.
That's the standard way. Everybody's gone on like that.
So very well said. Absolutely. Any other question to Dr. Harpal from anyone before we start with the next session? Any other question to any speaker for that matter? Any comments? Okay, so I presume not much. So let's jump on to the third session, which is final. Can I invite Dr. Rashid Anjum to start with his talk on congenital muscular torticollis outcome of release? Over to Rashid.
Thank you, sir. Can I share my screen?
Yeah.
So good evening. At the outset, I would like to thank Professor Sanjeev Gupta sir and Dr. Abdul Ghani sir for giving me this opportunity today. I would be talking on the outcome of unipolar release of sternocleidomastoid in congenital muscular torticollis. Again, I would like to thank my mentor and Professor Ashok Johri sir for all the clinical data and the surgical technique and the intraoperative tests described by him that we used. So congenital muscular torticollis is the third commonest congenital orthopedic problem in children after DDH and clubfoot with an incidence of 0.3 to 1.9 per 1,000. It has a slight right-sided predominance, although it's usually diagnosed early in the infancy and can be treated with exercises as well in most of the cases, but neglected cases are still very common in the developing countries like ours. Clinically, it's characterized by tilting of the head toward the affected side. The chin is rotated away toward the opposite side. The sternocleidomastoid muscle is short, inelastic, and in untreated cases, it can be associated with facial asymmetry, plagiocephaly, and other parameters. The earlier diagnosis case can be treated conservatively, but late presenters may need surgical intervention. And when surgery is needed, an early surgical intervention in less than 4 years of the children has a better prognosis and outcome compared to older kids. So if we'll keep this, if it is left untreated, there is an increased incidence of increasing facial asymmetry, whereas vision issue. Conservative treatment with exercises and the strict physiotherapy protocol is successful in initial years up to 2 to 3 years of the age. After that, they will need surgical intervention. And in delayed cases, even in adulthood, the surgery is thought to prove to be of the benefit, although facial asymmetry will not reverse, but the posture improves to a great extent. So there are different scoring systems that we use to analyze the outcomes, the objective manners in which there is modified Chang-Tang scores, modified Lee scores, and the clinical parameters like the head tilt, improvement, posture, appearance, and the more recently the gaze angle also. We have used the modified Lee in this study. But there is also a need of intraoperative assessment because a thorough release of sternocleidomastoid muscle is very important. And there may be other tight structures along with the sternocleidomastoid that need to be released. Incomplete release will lead to a suboptimal outcome. So this is a test that is described by Professor Ashok Johri. We have used it in intraoperatively assessment. I will just run it briefly. It's a schematic video animated. So on the left side, the sternocleidomastoid is normal, and if we glide the neck, it's a translation movement. You can see that it is stretching and the neck is translating to the left side. But on the right, the muscle is inelastic, fibrotic, and the translation movements are less. So we can use it intraoperatively in the preoperative method and then compare in the intraoperative method to assess the release of the sternocleidomastoid muscle. So I will be presenting it's a retrospective study. I will be presenting the data of the patient that were operated either during my tenure as a fellow or that of which the follow-up was with me only. So they had no previous surgical intervention and there was no other associated abnormalities, no vascular, no neurogenic or the vertebral anomalies in these patients. We have recorded all the details, including birth history, clinical examination, preoperative assessment of the range of motion for analysis. This is our surgical technique. We made a 3 centimeter incision on the inferior sternocleidomastoid muscle. It was 1 centimeter above the clavicle. Both the sternal and clavicular heads were released, and all tight facial structures were released with due precautions of the neurovascular structure. We did not release carotid sheath in any of our cases, though it has been done in a few cases I have seen in our literature. So this is the picture showing us clavicular head of the sternocleidomastoid isolated. We always used electrocautery to cut release this distal end. These are the intraoperatively neck motion to assess. If you can see on the images, the chin is also marked and there is a vertical line on the sternum. So that's how we assess the translation of the movement intraoperatively to see how is our release, is it complete or not. Again, this is a subcuticle closure of the final picture. So this is the glide test. If you can see preoperatively on the right-sided image, the glide is limited to only 1.5 centimeter, whereas on the left it's almost more than 5.5 centimeters. So post-operatively, you can compare. You can see the glide on the right side has also improved to 4.5 centimeters. Unfortunately, I don't have that video. It's not of good quality of intraoperative assessment of this glide test. So this is how that's how we test it. So we had a total of 27 patients with a mean age of 6.67 years and a mean follow-up of 8.5 years. And there were no surgery-related complications or recurrence or resurgery in any of our cases. The mean preoperative deficit in rotation was 11.3 degrees and lateral bending was 14.4 degrees. There was a significant difference between the pre and post-operative neck range of motion, head tilt in translation. And according to the modified Lee scoring system, 19 patients in this series had excellent results, 8 had good results. The post-operatively, we managed these patients in a cervical hard wedged collar, which was usually custom made for the kid for 6 to 8 weeks. Physiotherapy, intermittent supervised exercises like lateral bending, rotation were started at 1 week post-operatively. The patient was followed over 3 months, 6 months, and 1 yearly, and thereafter every year. The final assessment was again done like the modified Lee scoring system. This is one of the case example, and if you can just see images at the 2-year post-operative and the 5-year post-operative showing excellent range of motion and facial symmetry is okay. The head is almost central. Another case of a 3-year-old child who was operated for unipolar release at 3 months post-op and again at 3-year post-operative follow-up showing good correction. So this was a study by Shim et al. That was published in Journal of Bone and Joint Surgery, British in 2008. So when they compared the results of unipolar release in older children of more than 4 years of age, there was no significant difference between unipolar and bipolar release in all those patients. Almost 15 patients of the unipolar and 10 patients of the bipolar patient. And functional satisfaction and overall score were comparable. Similarly, another study by Professor Song et al. From Korea, in which 19 cases had a unipolar release, of which 15 patients or 80%, almost 80% were having a good outcome and 4 had a poor outcome. So to conclude, my point is that unipolar release is a safe and effective treatment for correction of congenital muscular torticollis. Unipolar release gives excellent results with improvement in range of neck movements and patient satisfaction in early as well as late or neglected cases. Complete release as determined by the intraoperative movement of the neck assures a good result with the unipolar release. Thank you.
Thank you, Rashid. Wonderful presentation. Next, my dearest Dr. Mohammed Hasib from UK. He is going to speak on fragility fracture of the pelvis. Over to Hasib.
Thank you very much, sir. Can you see my screen now?
Yeah, I can see. Put on the slideshow, please. Thank you.
Good evening, everyone. It's been a great variety and mix of excellent talks. So I'm not sure I can match up to that. And my presentation is anyway a lot black and white. I wanted to speak about both pelvic ring and acetabular fractures, but because of time constraints, I had to restrict myself to pelvic ring because one, I love pelvises, and two, I think this part of orthopedics is kind of neglected in general and in our region in particular, especially in Jammu and Kashmir. The objectives are to understand the spectrum and the burden of fragility fractures of the pelvis, understand the management principles, and then be able to enumerate or and list what types of fixations exist and what we can use to manage these. There are fragility fractures of the pelvis. They're popularly called FFPs. With increasing life expectancy, as you would expect with any other type of fragility fractures, the incidence does increase. Osteoporosis is the contributing factor. Maybe it's mostly related to age, but you may on occasion find a younger patient who's on steroids or has had radiation therapy, which affects the bone mineral density. And the incidence is increasing, contrary to other fragility fractures like neck or femur fractures. The incidence of these pelvic fractures is increasing. They are usually low energy fractures and result mostly in an acute setting. You will find that they come to the A&E with a simple fall from standing height. Sometimes they will present to your clinic, outpatient clinic, with no clear history of trauma and just long-standing pain. These injuries are usually isolated, and consequently, unlike high-energy fractures of the pelvis in younger patients or high-energy fractures in general, they are not usually associated with any hemodynamic instability. But you should be aware of the occasional patient who will be on long-term anticoagulation of some kind, and they can bleed, this should be taken care of. You'll have patients will often complain of pain. They'll say hip pain, but it's usually located in the groin because that's where the rami are. Or if the fracture is more close to the symphysis, then it'll be central. If the fracture is at the back, which it frequently is, they will complain of some degree of lower back pain or pain in the buttock. What it means for the patient is they lose their mobility. Pain is the primary problem. And with reduction in mobility come the complications of recumbency, as we all know. And you'd be surprised that the mortality at 1 year is on an average, according to this study, is 27%, but on an average, it's between 20 and 25% after fragility pelvic fractures. And many, if not most, do not return to their previous baseline of activity or function. And surprisingly, while we have guidelines for managing fragility hip fractures or other fractures, we don't have the same for pelvic fractures, when the morbidity they cause is in no way less. The patterns of these fractures, either they can involve the anterior ring, the posterior ring, or both. It is characteristic that wide displacements are not common because ligaments are intact because the mechanism is low. And the fractures at the back, sacral fractures, may be of patterns that may be associated with spinopelvic dissociation or instability. And these fractures progress. So you may find a patient who has an isolated ramus fracture and you manage them non-op or with analgesia and mobilization, but they do not get well, they get worse. So the pelvic ring is weak and under strain, and when it fails at one point, if it's untreated or unaddressed, these fractures may propagate and you'll find more fractures in other parts of the ring as time goes on. I'd earlier asked on the group to have a look at this classification system. I just think it makes my job a little bit easier. This is the young and Burgess that all of us are familiar with. Not all of these types are pertinent to fragility fractures. I think the lateral compression types are the most important because that's what the mechanism usually is. Sacral fractures, we know based on the zones 1, 2, 3, 2 is the transforaminal, 1 is on the outer side, and 3 is fractures on the medial side. Roy Camille then divided the type 3 fractures into, they described the patterns of sacral fracture, including H type, U type, lambda, and T types. The H and U types, because of the transverse element and bilateral vertical elements, are equivalent with spinopelvic dissociation, which may or may not be unstable. Romans a few years ago introduced a new classification system to describe the patterns of pelvic fragility fractures, and it's a great system. And there's 4 types with associated subtypes. Essentially, type 1 is fracture of just the anterior ring, which may be 1A unilateral, 1B bilateral. Type 2 is fractures of both the anterior and posterior pelvic ring, but the posterior ring fractures are undisplaced. And depending on how bad the posterior fracture is, it's 2A, 2B, and 2C. Type 3 is displaced posterior ring, but unilateral. And type 4 is bilateral posterior ring involvement with displacement. So this means the posterior pelvic ring includes the sacrum and the parasacral ilium. And in type 4, we include the spinopelvic patterns. This basically is also important because this classification, these types, increasing grade of or type means increasing instability and potential need for fixation. So what does it mean for us? So his classification was based on 245 patients, and you'll be surprised that only 18% of these had type 1 or isolated anterior ring fractures. So when you see an old person with a ramus fracture or bilateral ramus fractures, before you label them that, be careful that you ensure that you have excluded posterior injuries. Most of his patients, more than about 50%, belong to type 2, which, if you equate it with young Burgess, are basically LC1 fracture patterns. And a fifth of them belong to type 4, which are very unstable and need fixation. For the patient, it means pain and loss of mobility, as we discussed. And pain is an indicator of instability. And if it's left unaddressed, and they can move up a Romans type and move up from 1 to 2 and 3 and more if left unaddressed. X-rays are standard. We know the views for pelvises are AP, inlet and outlet. CT scans are often very useful. I think we should have a low threshold for CT scanning a patient if there's a suspicion of posterior ring involvement. MRI scans are useful in the setting of stress fractures that are still evolving, incomplete fractures which are not evident on CT in patients who may present, for example, with chronic low back pain which is otherwise unexplained. The approach to these patients has to involve old people's services, a geriatrician or a medical doctor with interest in managing these patients. They need a metabolic evaluation. They need the necessary treatment that we do for all other fragility fractures. They need a physiotherapist who helps them mobilize. And according to this was recently published in JBJS American, that 40% of those who do not receive medical management of osteoporosis after fragility fracture of the pelvis will within 2 years develop fragility fractures elsewhere. So how do you treat them? So stable fractures, the principles are the same. Stable fractures are treated conservatively, which means most Romans 1s and some of Romans 2s. And we give them analgesia, maybe rest for a few days, and the goal is to mobilize as early as they can. Get them out of bed, mobilize full weight bearing. There is no concept of non-weight bearing, bed rest. You mobilize, ask them to walk with whatever aids. It's usually amounts to a Zimmer frame, but they need to walk. Operative treatment is reserved for the unstable types, including type 3 and 4, and type 2, which are unstable, which means you can trial them on conservative and then they will fail. They will be painful weeks after the initial conservative trial, and then you'll have to fix them. The principles of fixation are different from high energy pelvic ring injuries in younger people. These should be minimally invasive operations. We are aiming at a reasonable reduction. It does not have to be anatomic. The fixation has to be stable, and the aim is to relieve pain and ensure mobilization of the patient. The fixation methods are various. Popular ones for the posterior ring are iliosacral and transsacral screws. We have to keep in mind that these are old patients with scanty bone, osteoporotic, so we use large diameter screws, and when you put in the screws, you have to be mindful of sacral dysmorphism, and sometimes in very weak bone, you may use cement augmentation. Transsacral screws have revolutionized with longer screws. The most of the purchase is from the outer cortices of the ilium on each side. Earlier transiliac bridging bars and transsacral bars used to be popular. They provide compression. They are still used in some places. Transiliac bridging constructs are similar to like posterior infixes, in which you do LC2 bolts and a bar, like a connecting bar in the middle. I'll show you some a case after that. Anterior ring fixation is usually with Ramesh screws, minimally invasive. Sometimes you may need a plate and screw fixation, especially if it's an old fracture or a non-union or very unstable. Infixes or internal fixators, the kind of internal fixators basically have two screws on each side of the pelvis and a subcutaneous rod. They have revolutionized the management. At least in our center, they're very popular. But you have to be mindful that there's a risk of injuring the lateral cutaneous femoral nerve. And because they are subcutaneous and prominent, sometimes, well, often they need to be removed. But the occasional patient will not mind it, and they just carry on with it. We designed a randomized controlled trial for LC1 type fragility fractures, which are most of Romans 2 and 3, which are the most common type. It's called the LIFE trial, but because of the pandemic, it's on hold. I think we have recently started. It's basically comparing non-op management versus an anterior infix for LC1 type fragility fractures. Here are some case examples. This lady, as 78 years old, fell off two steps. You can see there's a displaced ramus fracture on the left. There's an undisplaced root of ramus fracture on the right. Not uncommonly, people they may be sent home saying these are just ramus fractures. But if you CT scan them, you find a complete a sacral fracture, and you think how unstable they can be. So you put them to sleep and you stress them in lateral compression. This is how much they move. So you can imagine this is the degree of instability, and of course this is very very painful for the patient. So these get screws and an infix for us because they're minimally invasive. The comminuted fragments can be spanned well. They're very stable, and you can mobilize them straight after. Here's another patient with a 76-year-old female. She has a slightly different type of fracture. I tried to delete the patient identifier. Ignore that, please. So you see on the right upper corner, this is an LC2 type fracture. There's a crescent fracture, and at the front there are length unstable horizontal ramus fractures. So we aimed at percutaneous manipulation and just to align that LC2 corridor to the iliac wing and stabilized it with a what we call an LC2 screw, which is a screw which runs from the AIIS, anterior inferior iliac spine, to the posterior superior iliac spine. And that stabilizes that component, and then you reinforce the rest of the ring with a transsacral screw and an infix. Here's another patient with bilateral rami fractures and who had been suffering for a few months before someone decided to get a CT scan, and they found that these fractures were now becoming old, and she had sacral fractures, and she'd failed non-op for about 2 months before she was referred to us. We fixed it in our usual fashion, but in this case, we used ramus screws for stabilizing the rami. Spinopelvic dissociations in H and U-shaped fractures, they can be stabilized by transsacral screws alone, or lump of pelvic fixation, or a combination. It depends on what the level of the transverse element of the U or H-shaped fracture is. If it's low enough and you get enough bone in the sacrum to fix and compress S1 and S2, maybe 2 or 3 screws, then you may choose to do just SI screws. Otherwise, it's preferable to neutralize or reinforce the construct with a lump of pelvic fixation, which is called a triangular type of construct. I didn't have an X-ray. I'm sorry. This is basically what a unilateral lumbopelvic fixation with an SI screw would look like. So in summary, fragility fractures of the pelvis are increasing in incidence because people are living longer, and about 82% in Roman series, most involve the posterior ring, and they're unstable and painful. And these unstable fractures need to be identified and fixed appropriately to ensure early mobilization, as you would do for example, hip fractures. These are my references. Thank you.
Thank you, Ashish. Wonderful presentation and very well delivered lecture. Can I invite another speaker and the last speaker of the session? One of my another favorite, Dr. Mohammed Azhar-ud, all the way from the top of the world and top of India, Leh Ladakh. Okay, over to you, Azhar, who's going to speak on surgical dislocation for femoral head fracture, safe surgical dislocation. Thank you.
Good evening, everyone. Am I audible, sir?
Yes, you are.
Yeah, I'll start my share. I'll share the screen. Okay, good evening, everyone. First of all, I'd like to thank Dr. Sanjeev Gupta and Dr. Abdul Ghani for giving me an opportunity to be a part of this star-studded 6th annual Jammu Trauma Meet 2021. I'd be speaking on Gans et al. Safe surgical dislocation of the hip for femoral head fractures. So this is the part of the world that I live in. It's very cold out here. I'm the only speaker to be in jacket, I observe. So traumatic hip dislocation and ALS, they are very uncommon injuries, but hip dislocations may be associated with fractures of the acetabular, femoral head and neck. The incidence of femoral head fractures with a posterior dislocation hip is around 7%, and they have been historically been associated with very poor outcomes. So if we happen to get such a case wherein there is a femoral head fracture and a dislocation of the hip, it needs to be dealt with very urgently so as to restore the blood supply to the femoral head. And displaced isolated head fractures, Pipkin 1 and 2 injuries with incongruent reductions need open surgery. Now, going through our books, one becomes very confused, as there's no system that provides absolute recommendation for fracture management or has validated prognostic value. Most are purely descriptive. So in fractures which are treated surgically, the surgical approach, the fragment fixation or excision, and fracture fixation techniques have been debated. This is a landmark paper that was published in JBJS in the year 2001 by Professor Gans. Here he gifted us the safe surgical dislocation of the hip, wherein we had a full access to the hip joint without having the risk of avascular necrosis. Now, the indication of this safe surgical dislocation are femoroacetabular impingement, acetabulum fractures, Pipkin fractures. The Pipkin fractures are the femoral head fractures associated with posterior dislocation of the hip, slip capital femoral epiphysis, and Perthes disease. If we can see here, this is the Cocker-Langenbach approach that gives us exposure to the posterior column and the posterior wall of acetabulum. Then if we add to it a trochanteric flip extension, we uncover the superior part of the acetabulum because the gluteus medius and minimus are reflected anteriorly. But in the safe surgical dislocation that was described by Gans, wherein we go through a posterior approach, we do a trochanteric flip osteotomy and dislocate the hip anteriorly, we gain a 360-degree access as shown in this figure to the hip joint. We can visualize the femoral head, the acetabular rim, and the labrum. This was a paper published in JBJS in 2000 where the authors did a cadaveric study in 24 hips, wherein they injected a dye into the femoral artery and the internal iliac arteries, and they found that the deep branch of the medial circumflex femoral artery had a constant course. And this knowledge about the vascular supply of the femoral head is very important, especially for the surgeons who are intending to operate upon hips, wherein we are intending to preserve the hip. And this is the deep circumflex femoral artery, which arises from the profunda femoris or from the femoral artery. It lies between the pectineus muscle medially and iliopsoas laterally. Then it runs along the intertrochanteric crest, along the inferior border of obturator externus, and gives a trochanteric branch here, enters the joint capsule through the along the superior border of superior gemellus, and it ends by giving 4 to 5 retinacular vessels. This course of the deep branch of medial circumfemoral artery was found to be constant, and the authors found out that 90% of the femoral head was supplied by this medial circumflex femoral artery. The rest, 10 to 15% of the perfusion was done by central arteries in the ligamentum teres. So this is the most important slide of my today's talk. And if you happen to concentrate upon this, I'll be more than happy. You can see this is the deep branch of medial circumflex femoral artery, and its course along the inferior border of obturator externus going into the intertrochanteric crest. So the main crux of the safe surgical dislocation, which was given by Gans, is to protect this artery by keeping this obturator externus intact while dislocating the hip. There are certain shortcomings, of course, of this safe surgical dislocation because it being extensile in nature. It also requires a trochanteric osteotomy. There's a more prolonged recovery as compared to other procedures. So this is a case, a 28-year-old young gentleman who had met with a high velocity road traffic accident, had a posterior dislocation hip, and he had this the Pipkin 1, the femoral head fracture along with it. And most of the and as soon as I saw this X-ray, I shifted the patient to the OR, and under short general anesthesia, we attempted a close reduction. But we were able to get an incongruent reduction. Here you can see the post reduction CTs. The head, the femoral head was impinged against the posterior wall of the acetabular, and here is the fragment, the anteromedial fragment fracture of the femoral head. So we decided to open him up through the safe surgical dislocation, and in this safe surgical dislocation, the patient is positioned in a lateral decubitus position with the operative hip up. So in the original paper of the Gans et al., the safe surgical dislocation is done through a Cocker-Langenbach approach. The Cocker-Langenbach approach was given around 100 years back, where Langenbach was the teacher and Cocker the student. Langenbach initially intended to use this approach to drain abscess from the hip joint, wherein his student Cocker, he modified this approach by extending the incision more distally. In the Cocker-Langenbach approach here, the incision is along the femoral shaft, and then it goes to the tip of the greater trochanter, and it is curved posteriorly towards the posterior superior iliac spine. Keeping in mind that proximally the limit is roughly around 7 centimeters, because we need to preserve the inferior gluteal nerve, otherwise risking gluteus maximus from denervation. So here we see in the Cocker-Langenbach approach, the approach is made through the fibers of gluteus maximus. So Gibson's in 1950 gave an approach where he modified this posterior approach by the skin incision being slightly anterior to the Cocker-Langenbach approach, though it is still directed posteriorly, but the incision is slightly anterior proximally to the Cocker-Langenbach approach, and here the interval is between the gluteus maximus and the tensor fascia lata. So here in the Gibson's, we try to find the anterior border of gluteus maximus, and we retract it posteriorly. So the young gentleman that I showed the X-rays initially, we did this trochanteric flip osteotomy here. The posterior muscles were torn, and this the trochanteric osteotomy the trochanteric osteotomy here starts from the tip of the greater trochanter, and it extends along the greater troch to the posteriorly to the ridge of the vastus lateralis. We have to keep a cuff of the gluteus medius around 5 mm intact, so the line just passes anterior to the posterior most fibers of the gluteus medius here, and this this trochanter, the osteotomy that we have done is reflected anteriorly, while we reflect the vastus lateralis from the femoral shaft below and gluteus medius superiorly. So this is the thing that I was talking about. The osteotomy is done in internal rotation, and this is the osteotomy that was originally described by Gans. It was a straight osteotomy. We can also do a step cut osteotomy. The osteotomy begins at the tip of the trochanter and extends at the posterior border of the vastus, ridge of the vastus lateralis. And here is some amount of 5 mm cuff of gluteus medius that is kept intact. So after the trochanteric flap osteotomy, there comes the capsulotomy. The capsulotomy, which was advised by Gans, has a transverse limb along the long axis of the neck, and then the distal limb that is along the calcar, and proximally the horizontal limb is curved posteriorly along the labrum. So after that, we dislocate the hip joint by flexing, adducting, and external rotating it, and the hip is brought in front and into a sterile bag, and just push. We just dislocate the femoral neck with the help of a hook, a bone hook. And here you can see the patient that I initially showed the X-rays. Here is the fracture. It's a shear fracture of the anteromedial surface of the femoral head, and the femoral head fragment was the fragment was washed and curated, and provisional fixations were done and guide-wise passed, and Herbert headless screws, and they were countersunk, and reduction was achieved. And these are the post-op X-rays of the patient who had a posterior dislocation with Pipkin 1, wherein we had put 3 screws in the femoral head, the headless screws, and we used 2 4.5 mm cortical screws for fixing the trochanteric osteotomy aimed at the lesser trochanter. Now, this was a case that I happened to assist at a medical college, Jammu, before coming to Leh, and I was lucky enough to be a part of the team headed by Dr. Ghani. Then, as soon as I reached Leh, we had a similar patient with a similar case, wherein a 48-year-old female had a high-velocity road traffic accident, had a posterior dislocation of the hip with a Pipkin 1. Here is the dislocation was immediately reduced, but then she had this Pipkin 1. So initially, what used to happen was that such patients were referred to a high center, while as we decided to bring the implants from Delhi, and we decided to operate upon the patient after explaining them about all the pros and cons and about the prognosis of the disease. This is the Gibsons that we did with the posterior. The glute max is completely taken down posteriorly, and this is the trochanter, the abductors gluteus medius and minimus here, and vastus lateralis here. This is the mark we have made with the help of a cautery, and here is this is the posterior border of gluteus medius. Is some cuff of gluteus medius which is kept intact. So the maximal thickness being 1.5 centimeters. After dislocating, we observed the femoral head fracture that was here, and we washed it, curated, and provisional fixation with guide wires and a Herbert screw which was countersunk was done. This is the capsulotomy that was repaired, and this is the post-op X-ray of that lady. Fixed with 2 Herbert screws, and for the trochanteric osteotomy, we made use of 2 4.5 mm cortical screws aimed towards the lesser trochanter. This is the lateral views. Then in the post-op, we started knee range of motion, quadriceps strengthening, and toe touch weight bearing was started. The patient was made to walk toe touch weight bearing on a walker. And to all the students who are stressed over studying, especially the outgoing third-year PGs, my message is don't worry, you're not alone. And being the last speaker of today's webinar, I think my audience looks like this. So thanking all of you, thanking all of you for making me a part of this historic webinar.
Thank you. Wonderful. So no, they haven't slept actually. Dinner is ready, so obviously everyone is awake. So this is the end of the conference. So this dinner is being served. Okay. Right. Thank you. You can stop sharing screen.
Thank you, sir.
Great. Any question, any comments for this last session of the young dynamic faculty from outgoing from GMC Jammu? It feels actually, it gives me immense pleasure that yesterday there was PG students and today they're obviously, they've developed a huge name, and fortunately the skills they've acquired are immense. Thank you. Any comments and any question from anyone? Dr. Harpal, you want to say something?
A wonderfully organized meeting, Dr. Ghani. I'm really impressed, and I am sure a lot of hard work and planning has gone into it. And, you and Sanjeev as a team are working very hard, and it's so much, it makes it all the more better when you work as a team, and all my best wishes are with you.
Thank you. Thank you. Can I be a part-time manager as well? Just a question.
Manager of what?
Any like part. So just after Hatket as your finances, so I need to.
Next
Dr.
conference,
Ghani, you can manage your home.
Dr. Ghani,
Your wife will be very happy.
next conference में the talk will be how to manage well. जैसे डॉक्टर हरपाल ने किया ना आज फाइनेंस, डॉक्टर घनी will give a talk next year on how to manage. He's a very good manager, sir.
बात करी ना फाइनेंस की, डॉक्टर घनी देखो मैं एक चीज बोलता हूँ, ये सिर्फ हमारा प्रोफेशन है जिसमें इतने एथिक्स और इतनी चीजें बोली जाती हैं. You have spent your professional time in the organization of this conference, right?
Absolutely.
For what? कोई IAS, कोई IPS, कोई IIM का ग्रेजुएट, कोई IIT का ग्रेजुएट फ्री में कुछ नहीं करता. और हमारे यहाँ लोगों को शर्म आती है कहते हुए, यार मैंने 20,000 का काम किया है, I should be paid remuneration for it. US में they are all paid. You know, even AO course chairpersons are paid all over the world. Johnson & Johnson signs agreements with people to deliver guest lectures. Not only J&J, that's just an example. Every damn company, if they want you to deliver a guest lecture, they'll pay you for it.
Dr. Hasib get paid for signing a death certificate, you know. Just signing a death certificate, he get paid.
Doctor Sahab, I've got paid for signing medical certificates. It's the standard.
It is.
Hasib must be knowing disability certificates. If there's an industrial accident, you sign, you appear for an court appearance on video conference, you get paid for it.
No, that's true. Yeah.
Yeah,
now we need to do fellowship with Dr.
पैसे मांग रहा है, ये डॉक्टर है पैसे मांग रहा है.
हरपाल सर, अब फेलोशिप करनी पड़ेगी आपके पास.
डॉक्टर अल्ताफ, अपना वीडियो ऑन करो ना, शक्ल दिखाओ.
नहीं, शक्ल नहीं दिखा सकता, मैं थक गया हूँ.
सर आपके पास तो 2,000 का नोट देना है, उसने डिस्ट्रैक्टर लगा के 2-4 बन जाएंगे.
मैं तो सारा मुफ्त कर चुका आज तक सर. अब मेरे ख्याल से अब मैं सोच रहा हूँ गन्ने के खेत, ये सेब के बाग ले लो आपसे पूछ के.
How to grow your money by putting a distractor, lectured by Dr. Muzzafar. Dr. Rakesh Rajput, you want to have any closing comments?
Yeah, Ghani, I'm really very happy to be a part of this. The way you've actually organized it, very happy to see Hasib. I think you remember Hasib used to work with us, and you know, it's from here that he went to UK. He was a very bright guy. I mean, he's a very bright guy, not worse. And we always know he'll do very well. He just might do so well that he might not even come back to Jammu. That's the only trouble I'm seeing actually with him. He might not even come back to India.
You want him to come back to India or no? Yes.
I want him to come back. You see, I did not have the guts to come back to Jammu Kashmir. That was my problem. But my other issue was that I did all my basic also in Calcutta. So I had no medical connections with Jammu. But I think Hasib, I'll be very happy if he goes. And also that other young doctor in Leh, I mean, I'm very happy that, these people are beginning to do good work in such remote areas. I just, expect both of them to become members of EOPAS, which is our pelvic associations. So Hasib, at least you will have to become member.
Yes, of course. I was going to email you, sorry. And congratulations, you took over charge as the president recently.
No, it's fine.
Typical of Hasib.
Sir, congrats. मैंने कर दिया था message में, but sir ने मुझे form भी भेजा था, which I just got distracted by other stuff. But I'm going to apply for the membership. Yes, of course.
Yeah, please do. And you're working in a very good center, so bring back more expertise from there. But I have to say, since we've been here for last few years, India has really taken off in the pelvic acetabular trauma. And the lecture which you gave about the insufficiency fractures, there's a very good set being developed by EOPAS, led by Dinesh Kale from Belgaum. Those screw sets and all that. So maybe someday we'll discuss more details. We don't want to bore other people with that. And also, Dr. Azhar-ud, I think a small message. Many of these fractures which you are doing, dislocating the hip, they are actually inferior to the fovea, not that important fragments.
Yes,
and
sir.
Dislocating the whole hip and putting that into, at the actual head itself in jeopardy now, avascular, or how much ever safe surgical dislocation you do, you always take a risk. Try completely from posterior approach itself. You might be able to, do these fragments. I would say about 8 out of 10 times. You'll manage that. It's very tricky. You'll have to lift the table very high, really rotate the leg inside and go peeping inside, and you'll manage to do it. Though it will be very different angle, you will get 1 or 2 screws. That's enough, because these are really not articular weight bearing area.
Yes,
so I think for these ones to dislocate the whole hip is a bit putting the head at risk. But you got exposure to safe surgical dislocation, which is fantastic.
Thank you so much, sir. Thank you so much.
Very happy that you're doing there. So please write to us. We'll make you member of EOPAS.
Thank you so much,
and the
sir.
next conference is in Calcutta, so you're all welcome.
Oh,
and even Dr. Harpal, I think, sir, you're also, please do come to Calcutta.
Sure.
I've been in touch with you
already. I'll definitely come. Just a small word, sorry, Dr. Rajput. Hasib, if you're as good as Dr. Rajput says, don't come back to India.
No.
Oh, wow. I wasn't expecting that.
No,
my plan.
That's wrong advice. That's wrong advice. I've come back actually, and I'm
very biased. I'm very biased. It's not a place for 2 good people. Average is okay. If you're as good as Rakesh Rajput says, don't come.
He is excellent actually. There's no second thought about that.
Ghani, याद करो जब आपसे मैं पहली बारी मिला था Elizabeth course के लिए, तब मैंने आपसे भी यही पूछा था वापस क्यों आए?
Absolutely. But I'm not regretting that. Let me tell you frankly.
No. I'm not talking of regrets. I also came back. I don't regret. But मैं सब अच्छे बच्चों को बोलता हूँ कि इंडिया से बाहर जाओ.
Sir,
I think Dr. Harpal, you have a point for last 2-3 years. I have actually regretted. इसके पहले कभी नहीं regret किया. But last 2 साल से second thoughts बहुत बार हुई हैं, particularly in my state, where everything is going against doctors. I'm quite happy to share. My wife just left last month. She's gone to UK now. She's working there now. She's completely fed up with Indian scenario.
That's great. That's really a huge step.
And if things really get worse in 2 years' time, I might leave also.
Scary.
So Hasib, you're getting my answer now.
This is life-changing. I will have to rethink all my choices. All my plans are obviously now in jeopardy.
It's never too late. If Dr. Rakesh Rajput at this age is rethinking, it's never too late for you.
This comment is expunged from this meeting. Okay, so you're not listening to Dr. Rakesh Rajput. Okay.
No, it's just. I mean, I know there is merit to what he's saying. There's no doubt the system. There is a platform here. There's a system that you do your job. If you're good, you progress well. That is not necessarily the case back home. My thoughts when I first came here were, I came here looking for training, which I needed. I wanted to do pelvises. I wanted to do joints, both of which I have managed to do. And on top of it, I wanted to bring it back. And hopefully, maybe, it might come across as, a bit high-headed, but I wanted to bring it back and hopefully train other people if I could.
Okay.
And I mean, that hasn't changed, but what's been said now, it does also make sense. So I'm going to have to.
Glad it explains. You are not listening to this. Anyways, thank you very much, all of you. I think time to wind up, and obviously the dinner is getting ready, or not there, wherever you are. So thank you very much, everyone.
Thank you. It was nice seeing you.
Thank you,
It was
Ghani.
very nice seeing all of you, sir.
Thank you very much.
Take care.
Thank you.
Bye-bye.
Yeah.